با دکتر شوارتز چجوری احوال پرسی کنیم؟
Good morning.
Good morning, Professor Schwartz. Hi.
Good morning.
Thank you very much. I'm sorry to disturb you in early morning Toronto.
No problem.
So in a few minutes, I think in about 5-6 minutes, we will start. Thank you very much for your presence. Thank you. So you will be the first lecturer.
Okay. And how long do you want me to speak for?
I think you said for 1 hour. You will speak
Okay,
for 1 hour.
I'll probably try to take a little less, but that's good. I can do that. Yeah.
Okay, that's very good. Thank you very much.
Okay, I'm ready when you are.
Yes, thank you very much. We will let you know soon.
Hello, everyone. Welcome to the last day of the 32nd International Pediatric Congress. In today's webinar agenda, we will be covering intensive care in children with heart disease. Our purpose is to share experiences and sciences with other physicians around the world. So thank you for joining us and continue to hold. We will start in about 2 or 3 minutes. Thank you, everyone. Hmm? My name is Dr. Elmira Memar. I'm assistant professor here in Children Medical Center, Pediatrics Center of Excellence, Tehran University of Medical Sciences, and I'm so honored to be with you in the last day of our Congress, but actually not the least. As all of you know, Tehran University is the oldest and most well-known medical center in Iran nationally as well as internationally, and it is also one of the country's top research universities. This Congress is an international webinar that held by Pediatric Department of Tehran University. Children Medical Center Hospital was selected as the hub of excellence in pediatrics in 2008 by Ministry of Health and Medical Education. Our hospital services and facilities are open to all nationalities, irrespective of race, color, and creed. We believe that our ability to deliver the best healthcare is made possible through our team highly trained, dedicated, and committed professionals with our medical, nursing, and clinical services. I'd like to take a moment to thank our speakers, dearest panelists for joining us, and also I would like to thank our dearest audiences for joining this event. A few reminders before we get started. This webinar is broadcasting live on our YouTube. Information about our social media is provided on chat section. Due to the number of participants, make sure to mute your microphone during the lecture. If you have any question, we encourage you to ask them via chat section. Please feel free to ask your question at any point during the presentation using the chat section at the bottom right of your screen. We will reserve time at the end of each presentation to answer questions. We would do our best to answer as many questions as possible throughout today's event. I'd like to introduce today's panelists. First, we start with Professor Steven Schwartz, Professor of Pediatrics, Senior Associated Scientist, Interim Chief Department of Critical Care Medicine, Head Division of Cardiac Critical Care Medicine, Department of Critical Care Medicine and Pediatrics, University of Toronto, the Hospital for Sick Children. And after that, I want to introduce Professor Ajay Desai, is a consultant in pediatric intensive care medicine at Royal Brompton Hospital, London, United Kingdom. He is the director of pediatrics ECMO program with a special interest in ECMO resuscitation. He's training program director in London School of Pediatrics and co-chair for Science and Education Committee of Pediatric Critical Society. After we have Dr. Alejandro Flo, he is a staff of intensivist in the Department of Critical Care Medicine and an assistant professor of pediatrics in the Faculty of Medicine at the University of Toronto. His clinical expertise is in the management of critically ill children with congenital and acquired heart disease, including complex neonate with single ventricular circulation. He is an academic interest in the inflammatory and metabolic response to cardiopulmonary bypass surgery and the nutrition and metabolic support of critically ill children. Dear Professor Schwartz, good evening.
Hello. Good evening. Good morning. Thank you for having me. So I'm going to share my screen and get right to my talk.
Yes, now you are co-host and you can share your screen.
Okay. Can you see that?
Yes, it's okay.
Okay. So I'm going to speak about using inotropes and vasodilators, pulmonary and systemic circulation. No relationship to disclose other than the title of this talk makes it sound like it will be about pharmacology, but it will in fact be about physiology. So the key points that I want to make is that you have only so many tools to manipulate the circulation. You really have vasodilators and vasoconstrictors, and those come with or without inotropic and beta blockade properties. The key thing in deciding what drugs to use is you need to know what you're treating. In the systemic circulation, you may be trying to change the blood pressure to make it go higher or lower. And in that case, you need to be focused on whether you're treating cardiac output or systemic vascular resistance. Remember always that cardiac output is controlled by preload, afterload, contractility, the rate and rhythm, the distribution of pulmonary blood flow, distribution of systemic and pulmonary blood flow in single ventricle circulations, whether or not they're residual lesions, such as AV valve insufficiency, and by ventricular-ventricular interactions. The pulmonary circulation is determined by pulmonary artery pressure versus cardiac output. Again, preload, afterload, contractility, residual lesions, and ventricular-ventricular interactions. And we'll spend most of this talk going through these things. And so I often get asked, well, what drugs do you use for this? Or do you have an algorithm or a guideline for how you use your inotropes? And I think the thing to emphasize is that it's less important which specific agent you choose than it is to choose something that treats the underlying problem. Also, I'll show you examples. This is a lot of the, we're going to start by going through some basic physiology, but then we're going to do a lot of case-based examinations. And you'll see that sometimes less is more, or the solutions are in fact even non-pharmacological. And I'll just start by making the point, not all hypertension or hypotension is the same. Again, the physiology is what matters. So I'm going to just present a couple of cases without going through what we do about them, then talk about physiology, and then we'll come back to the cases. So in terms of patients with hypotension, the first case is a 15-year-old with a history of leukemia who had chemotherapy with cardiotoxic agents, presents to the ICU with a 1-month history of decreased left ventricular function, is very tachycardic with a heart rate of 180, tachypnic with a respiratory rate of 46, hypotensive with a blood pressure of 85/52, reasonably well saturated at 95%, but on 3.5 liters of oxygen. Second example of hypotension, a Norwood patient with hypoplastic left heart syndrome who's had a hybrid Norwood, again, very tachycardic, heart rate 195, again, hypotensive, 56/34, saturation is 72%, which is low, but acceptable for somebody with this physiology, but the mixed venous set is 28%, and the lactate has gone from 2.2 to 5.4 millimoles per liter. Third example of hypotension, 6-month-old with tetralogy who's just come back from the operating room with a repair, has no important residual lesions, no right ventricular outflow tract obstruction, no tricuspid insufficiency, no residual shunts. The heart rate is again mildly tachycardic, 150, hypotensive, just like the other patients. Blood pressure is 53/34 with a mean of 41. Well saturated, 100%, and the right atrial pressure is high at 22 millimeters of mercury. Has already received 20 mils per kilo of fluid. The mixed venous set is 40, which is low. The lactate is 2.1, which is acceptable. and is making urine at 1 mL per kilo per hour. Fourth example of hypotension. 3-year-old who's had a long history of left-sided obstructive lesions in a small left side, so coarct repair and a small left ventricle, has had an aortic valve commissurotomy and coarctation repair, and then a Ross Cono, and had been on ECMO for 9 days postoperatively. Now has pulmonary hypertension and suprasystemic pulmonary artery pressure and restricted left ventricular physiology, comes to the ICU after undergoing a heart transplant, and 12 hours post-transplant, the CVP has risen from 8 to 13. The blood pressure has gone from 89/58 down to 74/35. So again, hypotensive. And the mixed venous set is 41%. So those are 4 examples of patients who show up in the cardiac ICU and are hypotensive. But I'll ask, are all these the same? And the answer is obviously they're not, or it wouldn't be a very interesting talk. Let's look at hypertension. An 8-year-old presents with 2 weeks of fatigue, now with shortness of breath, tachycardic, 120, blood pressure is 120/90, so hypertensive for an 8-year-old, slightly decreased saturation at 90%. Chest x-ray has pulmonary edema, and the echo shows an ejection fraction of 30%. The second is a 2-year-old who had a coarctation repair, slightly tachycardic at 110, blood pressure is quite high at 150/110, again, fully saturated, chest x-ray is clear, well perfused, low lactate, good mixed venous saturation, and the echo shows normal ventricular function. And I'll ask, are these 2 cases of hypertension the same? And in fact, again, they're not. And we'll go through them, but I think it's probably pretty obvious to any of you who care for these patients that these are not the same. So, what are your options? Well, when you are treating hypotension, you can use systemic vasoconstriction. Most of the drugs we use are alpha agonists like norepinephrine, and they may have inotropic properties or not, so you can use phenylephrine if you really want no inotropic properties. You can use epinephrine if you want more inotropic properties, and then there's vasopressin, which is a pure vasoconstrictor as well. You can use systemic vasodilators. So most are primary direct vasodilators. And again, they may have inotropic properties like milrinone or levosimendan, or they may be beta blockers like esmolol, or they may be drugs like nitroprusside or hydralazine if you're not using a continuous infusion. For pulmonary vasodilation, you can use inhaled nitric oxide, sildenafil, or enteral pulmonary vasodilators. And in the past, we've used systemic vasodilators, hoping that they somehow act primarily on the pulmonary circulation. So now the physiology. So this is a pressure volume loop. You may be familiar with these, but I'll just give you a quick guided tour. The volume is on the x-axis, pressure is on the y-axis. So if you start here, the first thing that happens in the cardiac cycle is diastolic filling, where volume increases and pressure increases only slightly at the end. This is followed by isovolumic contraction, where the pressure rises, but the volume doesn't change until the aortic valve opens. Once the valve opens, you get systolic emptying, slightly more rise in pressure, but then the pressure starts to fall as the ventricle empties. The aortic valve closes, and you get isovolumic relaxation until the mitral valve opens. The distance on the x-axis between the end systolic volume and end diastolic volume is the stroke volume. You're all aware of the Frank-Starling mechanism. If you increase preload, you give more filling of the ventricle in diastole, you get the same pressure rise, but you get a bigger stroke volume because the ventricle empties to the same end diastolic volume, assuming afterload and contractility are kept the same. If you increase afterload, the ventricle has to generate a higher pressure before the aortic valve opens, and that results in the ventricle ejecting to a higher end systolic volume. In other words, the stroke volume decreases as afterload increases. Contractility is hard to measure at the bedside, but it's important to understand that it's an intrinsic property of the myocardium, and it's not, when you measure it, you have to measure it independently of changes in preload and afterload, which is why it's so hard to assess at the bedside. But the way you would define contractility in the lab is you would generate a series of these pressure volume curves at different afterloads. And as long as the contractility stayed the same during the experiment, even as you changed afterload, the end systolic pressure volume points would line up on a line, meaning that for each increment in afterload, you would get a predictable decrement or decrease in stroke volume. The slope of this line is called the end systolic elastance, and that is considered a load-independent measure of ventricular contractility. If you gave a drug like dobutamine to increase contractility and regenerated these curves, you would get this end systolic elastance line with a steeper slope, meaning a heart that has better contractility has a smaller decrement in stroke volume for each increase in afterload. A heart with more contractility is better able to tolerate changes in loading. It's also important to understand that there are ventricular-vascular interactions. So when the heart fails, so here's a normal pressure volume loop in blue, in green is a failing heart that's dilated, so the volumes are much higher and the stroke volume is lower, the contractility is less. There is also, if you draw a line between the end diastolic pressure volume point and the end systolic pressure volume point, this line has a slope, and that's called the end systolic, that's called the arterial elastance, and is a measure essentially of stiffness or afterload on the heart. And what tends to happen when the heart fails is the arterial elastance goes up. In other words, the arterial bed into which the ventricle is pumping is more constricted, and that in addition to the contractility being lower, the fact that this weakened heart is working against a higher afterload or a less receptive vascular system is also a problem that leads to many of the clinical symptoms that we see in patients with failing hearts. And this was shown very nicely in what's now a very old research paper that they took actual patients and they measured end systolic elastance and arterial elastance, and they found that in patients who were healthy, the normal heart worked at peak energy efficiency. The absolute value of the elastance, the end systolic elastance slope, was greater than the absolute value of the arterial elastance slope. And in other words, contractility exceeded afterload. Patients in compensated heart failure had a heart that worked at peak efficiency, peak work efficiency. So the slopes of these lines, the absolute value of the end systolic elastance over the arterial elastance was 1. The contractility was perfectly matched to the afterload, but what that means is that this heart isn't going to be able to withstand any change in afterload. And that's why the patient, in terms of clinical symptoms, appears as somebody with compensated heart failure. Those with decompensated heart failure, their arterial elastance far exceeded their contractility, their end systolic elastance. This is an inefficient heart, and the contractility simply doesn't match the afterload. So one of the solutions, as we'll see, isn't just improving contractility, which can be very hard to do, it's actually decreasing afterload. There are physiologic differences between the right ventricle and the left ventricle, and this becomes important when you're trying to figure out if your hypotension, for example, is caused by right ventricular failure or left ventricular failure, to the extent that you can differentiate these two. The right ventricle is energetically efficient, adapted to low afterload, has a low contractile reserve and a high afterload sensitivity. In other words, a healthy right ventricle exposed to afterload fails very quickly, whereas your left ventricle, unless it's very, very sick, clearly is able to function over a wider range of afterloads. The right ventricle is vulnerable to small hemodynamic change, and it contracts from the apex to the base. The left ventricle is very work efficient. It can pump against much greater loads, adapted to high afterload, high contractile reserve, and low afterload sensitivity. That's what allows you, for example, to exercise and raise your blood pressure and not have heart failure. Same idea, it's able to withstand a much larger hemodynamic range and has circumferential contraction with rotation and twisting. So it's important to just distinguish, this is a right ventricular pressure volume loop. It looks different than that left ventricular pressure volume loop. It looks more like a triangle, and that's because there is essentially no isovolumic contraction period with a right ventricle. Because the pressure in the pulmonary artery is low, as soon as the right ventricle starts to contract, blood starts to eject and the volume starts to decrease. And similarly, there isn't really any isovolumic relaxation period. This is, again, a right ventricular pressure volume loop. This is what happens when a right ventricle fails. Just like with the left ventricle, it dilates, it operates at a much higher volume and a much lower stroke volume. If over time, the right ventricle is exposed to higher pressures and is able to adapt, it develops a pressure volume loop that looks much more like a left ventricular pressure volume loop. This is a figure from a paper that demonstrates some of what I'm talking about. So this looked at intensive care patients, adult patients, and looked at changes in blood pressure and changes in stroke volume, and found that if you increased systemic pressure increased in patients, and you looked at the left ventricle, you see a decrease of stroke volume just as we'd expect, but a relatively gentle slope. If you acutely increase pressure in the right ventricle, you see a dramatic drop-off of right ventricular output and stroke volume, underscoring the idea that the right ventricle is very, very sensitive to acute changes in afterload. I think we all know that coronary blood flow in the left ventricle occurs primarily in diastole, but in the right ventricle, coronary blood flow occurs primarily in systole. And you can see this here. As you increase the systolic right ventricular pressure, the amount of coronary flow that occurs in the right coronary in systole versus diastole decreases in a fairly linear fashion. So as you acutely increase pulmonary artery pressure, in addition to imposing this acute afterload on the right ventricle, it tends to also cause a decrease in coronary blood flow, and that combination together is particularly detrimental. So with some of these principles in mind, let's go back to our cases. The first case was, again, a 15-year-old with a history of leukemia and chemotherapy with cardiotoxic agents, who had decreased LV function, moderately decreased LV function for about a month, and is now showing up in shock, tachycardic, tachypnic, hypotensive, and needing a fair amount of supplemental oxygen to maintain saturations. Shows up to us from an outside hospital on dopamine at 10 mics per kilogram per minute, norepinephrine at 0.2 mics per kilo per minute, and milrinone at 0.25. So a little bit of milrinone, a lot of norepinephrine, and a lot of dopamine. So your effects here are a little bit of inotropic support with the milrinone, and then a lot of vasoconstriction, because whoever made these treatment decisions is focused on the blood pressure. But remember, your problem here is low cardiac output and a low stroke volume, leading to hypotension. And we've just talked a lot about how important managing afterload is in somebody with poor contractility. This is an echocardiogram. You can see that this patient's ejection fraction now is much less than the 46% it was reported to be. Here's a four-chamber view again showing the same thing. So dilated heart, this is the kind of echo where you go back and you re-examine the patient to make sure they still have pulses and that they're alive. And a consequence of a dilated ventricle is often AV valve insufficiency. And you can see here that there is in fact significant mitral regurgitation. So what did we do? Well, recognizing that the problem is a contractility problem, not primarily a blood pressure problem. It's not that there's a low SVR, and just giving drugs to increase the SVR isn't going to help. In addition, you already have a dilated ventricle and mitral regurgitation. Fluids aren't going to be a good idea. We started epinephrine to give better support for contractility. We probably would have increased the milrinone initially, except that the patient was already hypotensive. I will say that this is a very precarious situation. You're not really very far away from having to go on ECMO here. But as we started the epinephrine at a modest dose, 0.05 mics per kilo per minute, trying to get improvements in contractility without too much additional vasoconstriction, the blood pressure did start to come up. that immediately allowed us to wean the norepinephrine and dopamine off, and the blood pressure didn't change. Why is that? Because as we decreased the systemic vasoconstriction, we got better cardiac output, and we were exchanging vascular resistance for cardiac output in order to maintain blood pressure. And that's obviously a much better place for a patient in shock who really needs more oxygen delivery. We were able to aggressively diurese the patient with several liters of negative fluid balance over 4 to 5 days. Again, that actually decreased the heart rate and improved the blood pressure. And then eventually she went on to receive a left ventricular assist device, and a couple of years later, a heart transplant. The issue here again is recognizing that the problem, yes, the hypotension is a problem, but the real problem is decreased cardiac output, and the principles of treating decreased cardiac output are to improve contractility and reduce afterload. So high doses of dopamine and norepinephrine are not going to, excuse me, are not going to help your situation. Excuse me. This was her x-ray when she first presented. This was her x-ray after we were able to change her therapy. Her pulmonary edema was resolved because we were able to not only diurese her, but because we were able to reduce her left ventricular end diastolic pressure by improving contractility and decreasing systemic vascular resistance. We'll move on to the second case. This is a Norwood, hybrid Norwood, so stenting the pulmonary, stenting the ductus arteriosus and banding the pulmonary arteries as a palliative treatment for hypoplastic left heart syndrome. Again, tachycardic, hypotensive, at low but adequate saturation, but a very low mixed venous saturation and a wide AVO2 difference, again indicating low cardiac output. This patient comes to us on milrinone at 0.5 and epinephrine at 0.05. Lactate is going up. Well, using the principles that I just described, it's easy to assume that this patient has some sort of ventricular contractility problem. And if that's the case, you might keep pushing some of these drugs like the epinephrine. But this patient's already on a pretty good regimen of drugs for somebody whose problem is low contractility. So you need to ask the question, is that really the problem? And here's the patient's echocardiogram. And when you look at the right ventricle, you see that it's contracting just fine. Giving more inotropy here isn't the issue. And in fact, this left ventricle is dilated, and the problem here isn't the systolic function of the right ventricle, it's the diastolic function of the right ventricle. And this actually shows what happened when the first patient first came back. They got an increased epinephrine dose, and you can see that the contractility of this right ventricle is fine, but its diastolic volume is even less than it was before. And we actually published some data a long time ago that sort of supports what's happening here. We looked at 108 Norwood patients, looked at measures of LV size, mass, and function on their initial newborn echo, and then looked what happened to them as they got older through their Fontan. And it turned out the thicker their interventricular septum, the more left ventricular mass they had, the lower their survival was over time. And we attributed this to essentially that thick left ventricle riding piggyback on the right ventricle and causing problems with diastolic filling. Similarly, this is some unpublished data, but we used to measure oxygen consumption regularly by respiratory mass spectrometry and calculated cardiac output using FIC. And what we found out, what you can see in this chart here, this looks at various measures of left ventricular mass and correlates them with measures of cardiac output. And we found that the more dilated the left ventricle, the more negative impact it had on cardiac output and right ventricular function in the first 24 hours post-operatively. So what we actually did once we saw this echo, it totally changed our management. We weaned the epinephrine off completely. You don't need epinephrine for a patient whose contractility is good. That actually decreased the heart rate, which gave more time for diastolic filling, and maybe paradoxically to what you would think, raised the blood pressure and increased the mixed venous saturation. So again, here's what this echo looked like at the beginning. And as the heart rate slowed down, you can see that we're actually getting better filling. Over the next couple of weeks, the ventricle actually remodeled, and the left ventricle remodeled, and the right ventricle again continued to improve. Next example is a biventricular patient again, like the first one, 6-month-old with tetralogy of Fallot, who's now had a tetralogy repair, no residual lesions, no RV outflow tract obstruction, no tricuspid insufficiency, no residual shunts, again presents hypotensive. Blood pressure is 53/34, heart rate's 150, saturation's normal, but the right atrial pressure is very high, has already gotten some fluid, so probably giving more fluid isn't going to be helpful with this high right atrial pressure. Is on milrinone, norepinephrine, and vasopressin. So we're obviously worried about the blood pressure, and we know the patient has good contractility, but we still have a problem. The mixed venous sat is low, the lactate is still acceptable, so we haven't had end organ ischemia yet, but we're going to get there if we're not careful. And there's modest but not great urine output. So this patient has restrictive right ventricular physiology, and we know that because we know that this is common in tetralogy patients, and everything is consistent with that. The very high right atrial pressure in the face of no residual lesions and what appears to be good ventricular function. And the concept behind restrictive RV physiology is that a hypertrophied or very stiff right ventricle is restrictive to diastolic filling. And this is identified by antegrade flow from the right ventricle to the pulmonary artery at the end of diastole. And it's most commonly described in this exact situation after a tetralogy of Fallot repair. And it can impair cardiac output, raise CVP, promote third space fluid loss, and complicate cardiopulmonary interactions when the patient's on positive pressure ventilation. Restrictive physiology was first described in this paper by Cullen back in 1995, a restrictive physiology after a tetralogy repair, and they compared patients whose echoes showed that antegrade flow out the RV outflow tract in diastole versus those who didn't. And you can see those restrictive physiology were hypotensive, had poor urine output, were cool peripherally, were acidotic, although they weren't particularly that much more tachycardic. I mean, this patient here, these numbers are awful. This is a patient who's about to have a cardiac arrest. This is our patient's echo, and you can see this big dilated right ventricle with the septum bowing into the left ventricle. So in addition to the problem that the right ventricle is very stiff and is hard to fill, which decreases cardiac output, through ventricular-ventricular interactions, it actually exerts a negative effect on the left ventricle, making it hard to fill as well and compounding the problem. This is a long axis view of the same thing. Again, the right ventricle is pushing the septum into the left ventricle. So what did we do? Well, your problem here isn't something that drugs are going to solve. You can't give more fluid. There isn't pulmonary hypertension. Lowering the pulmonary artery pressure isn't really going to help. You need to give that right ventricle the ability to fill without compromising the left ventricle. In this case, our management was non-pharmacologic. We reopened the sternum and we had an immediate improvement in hemodynamics. The right atrial pressure decreased to 12 from 22. The blood pressure started to go up. The mixed venous set increased, and we were able to completely discontinue the vasoconstrictors. Very different case here of right ventricular failure. This is our 3-year-old with a history of left-sided obstructive lesions, known to have pulmonary hypertension, restrictive left ventricular physiology pre-op, but is now 12 hours after a heart transplant. The CVP is going up, the blood pressure is going down, and this suggests acute right ventricular failure. Patients on a high dose of milrinone, patients on epinephrine, norepinephrine, and is on nitric oxide because we know there's pulmonary hypertension and still in low output. This is this patient's echo. It's not a very good picture, I'm afraid, but you can see the right ventricle isn't working very well and there's tricuspid insufficiency. So I'm going to take a minute out before we go back to the patient and talk about why a patient like this is at high risk of having right ventricular failure after surgery. Well, what's happening in this surgery? Well, during bypass, all venous return is taken from the SVC and the IVC, or from the right atrium, depending on the kind of bypass circuit. there's no pulmonary flow through the pulmonary arteries. We know that the endothelial surface of the pulmonary arteries gets its oxygen supply primarily from the blood that circulates through the pulmonary arteries. So in other words, the endothelial surface of the pulmonary arteries is essentially deprived of its blood supply, and it becomes dysfunctional, and a dysfunctional endothelium fails to make nitric oxide. Unfortunately, it retains its ability to make endothelin, which is a vasoconstrictor. And so what happens in this situation is you get a preponderance of vasoconstriction. You don't get the balancing vasodilation with the nitric oxide, and you end up with pulmonary hypertension. This can happen in the systemic circulation as well after long periods of low flow bypass or deep hypothermic circulatory arrest. This phenomenon in the pulmonary circulation was shown really, really nicely in this paper out of Boston Children's Hospital from the mid-1990s. They took kids to the cath lab with VSDs and pulmonary hypertension and gave them acetylcholine. They saw when they gave acetylcholine a change in the pulmonary artery pressure. Acetylcholine functions as a pulmonary vasodilator by promoting the endothelium to make nitric oxide. It is what's called an endothelial dependent pulmonary vasodilator. You need an intact endothelium for acetylcholine to be able to have this effect on the pulmonary circulation. Patients went to the operating room, they had their VSDs closed, and they were again given acetylcholine with very minimal change in pulmonary artery pressure. They then were given inhaled nitric oxide, and they had the same change in their pulmonary artery pressure that they had had preoperatively with acetylcholine, showing very elegantly that the problem here is that the endothelium is no longer able to make nitric oxide for a period of time after cardiopulmonary bypass. Another phenomenon that comes into play, so that's the first phenomenon at play in this post-transplant patient, is that the patient already had high pulmonary artery pressure and the ability to generate a high pulmonary artery pressure. Now you're in a situation where there's decreased intrinsic nitric oxide, and so that pulmonary vascular resistance is going to be very high. A second phenomenon that's going on here or that you can at least take advantage of here, and we'll talk about this when we get to how we manage this, but the principle of myocardial crosstalk. It turns out, I don't know why I keep drawing on this. I didn't think I had my drawing on, but I don't know how to erase it. I'm sorry for the red lines. This is a nice schematic of muscle fibers in the heart, and you can see that
Sorry.
Sir, this inconvenience is not from our side. It is something out of our control. So if you can just ignore that and just continue with your great presentation.
I think I'm the one who's drawing them, but I don't know why. I don't think I have annotate on. But at any rate.
Okay, thank you. Thank you. Yeah, there is no problem. It is completely clear. Your presentation is completely clear.
Okay. Oh,
thank you.
So these fibers, you can see wrap circumferentially around the left ventricle, but there are other fibers that wrap both around the left ventricle and right ventricle. And we're going to come back to this because you can use, if your left ventricle is still working and your right ventricle is failing, you can get the left ventricle to drag the right ventricle along a little bit. And so if you can see through all my red lines here, this is a nice study, again, an older study. I'm not showing you any new literature. What they did in this experiment is they electrically isolated the left ventricle and the right ventricle. So they made it so that they were either electrically stimulating only the left ventricle or only the right ventricle. And seeing what happened in both the ventricle that was being electrically stimulated and in the other ventricle. And so, as you can imagine, if the left ventricle is the one generating pressure, and you stimulate it, you get a normal left ventricular pressure curve. But interestingly, when you're stimulating the left ventricle and there's no electrical activation of the right ventricle, the right ventricle is still able to generate a fair amount of pressure due to that myocardial crosstalk and those fibers that connect between the right and the left ventricle. Unfortunately, the right ventricle is not able to help the left ventricle out the same way. So when you stimulate the right ventricle, again, you get output from the right ventricle, but it doesn't really do anything for the left ventricle. But what this does mean is that if you have acute right ventricular failure, and if you have left ventricular failure as well, increasing inotropy will help both ventricles. But if you have a left ventricle that's working well and can tolerate more loading, you can actually increase the afterload on that well-functioning left ventricle. You can try to get it to have a slightly higher end diastolic pressure and start to push the septum back over into the right ventricle where it needs to be, and you may improve cardiac output. And this has been shown in some interesting models where people have used aortic constriction. They induce right ventricular failure in experimental animals by putting pulmonary artery bands on, and they actually can get the heart to compensate by constricting the aorta as well. So increasing afterload on a healthy left ventricle can actually help a failing right ventricle. So when we go back to our patient who's post-transplant, the ideal treatment here would improve this ventricular arterial coupling that we talked about way back in the beginning in the physiology. So we want to make sure our pulmonary artery pressure in this case is as low as it can be. We want to shift the ventricular septum. In this case, as the RV fails, it's pushed over in the LV. We want it to move into a more normal position. We have an LV that's working well. We want to take advantage of its ability to assist the right ventricle. And we want to help restore the systolic component of right coronary artery flow. Remember, I talked about an acutely pressure-loaded right ventricle has a change in coronary flow that's disadvantageous. And again, this is a transplanted heart. So even though this patient has had pulmonary hypertension for a long time, this heart has never seen pulmonary hypertension. So what did we do? Well, one of the problems is the right ventricle is very dilated. And so you can unload it. This is we have done this occasionally. It's an unusual maneuver, but we actually acutely removed blood. 150 milliliters of blood, so about 10 per kilo from this patient. Now this was done under echo guidance and watching what happened to the size of the right ventricle and to the tricuspid insufficiency, and obviously with a lot of hemodynamic monitoring. But as we removed blood, we actually saw the tricuspid insufficiency improve. We saw the right ventricle get a little bit smaller, and we actually saw a slight improvement in hemodynamics. This is a sort of innovative way to treat this. And again, it has to be done very carefully under the right guidance, but it can be helpful. We increased the norepinephrine. We could have added vasopressin. We did that, again, to increase that afterload on the healthy right ventricle and shift the septum back over into the RV to help LV filling. And these maneuvers, the chest was already open. These maneuvers increased the mixed venous sat from 41 to 56%. The lactate started to come down, the CVP came down, and the blood pressure went up. Now, this is not something that gets you, isn't going to get you through days and weeks of managing a patient like this, but it may get you through hours, keep you from going on ECMO, and if the underlying problem is starting to improve, in this case, in a post-transplant patient, as they recover from the ischemic time for the donor heart, the right ventricle may get better. The pulmonary vasculature may come more under control as you get farther out from bypass. You then get to a point where you don't necessarily need to do this, and you can back off of some of these things. So those are our hypotension cases. I'm just going to finish quickly with a couple of cases of hypertension. The first one, again, is like our first hypotension case. This is a patient in acute heart failure, but who isn't hypotensive. So 8-year-old, 2 weeks of fatigue, now with shortness of breath, tachycardic, hypertensive, slightly low sat, poor perfusion, chest x-ray shows pulmonary edema. Again, echo shows a low ejection fraction. And in this case, you can take advantage of the fact that the blood pressure is still high And now you can focus on afterload reduction and a little bit of supportive contractility. So here, we started milrinone at 0.5, gave a dose of Lasix. The blood pressure came down, the saturation increased because the pulmonary edema resolved, and then we were able to add nitroprusside, titrated up to 2 mics per kilo per minute to get the systolic blood pressure down to about 90, and perfusion improved. And these are really the cornerstones of management for anybody with hypertension and poor ventricular function who is in acute heart failure, which is support the contractility while decreasing the afterload and using diuretics. So that's fairly straightforward. The second hypertensive case is a 2-year-old after a coarctation repair. Again, fairly significant hypertension, 150 over 110. Chest x-ray is clear, the kid is well perfused, does not have a contractility issue. The issue here is all about systemic vascular resistance, and in fact, sometimes these hearts are hypercontractile after the acute release of afterload. So here we use nitroprusside. We didn't get much of a response. We switched to a beta blocker, esmolol, and titrated up, and we got a good response. There is some data, it's a little bit minimal, that's out there that suggests in these sorts of situations after relief of LV outflow tract obstruction, if you're treating hypertension, beta blockade is more effective than vasodilation. Again, probably because the heart is hypercontractile. So in summary, there are only so many agents with which you can manipulate vascular resistance and contractility. The specific drug that you choose is less important than having a thorough understanding of what you're treating and choosing drugs to treat the problem, not worrying about exactly which drug to choose. Vasoactive drugs are most useful if the primary problem is vascular tone. Sometimes less is more. So vasopressors are disadvantageous in systemic ventricular dysfunction unless there are coronary issues or cardiac arrest is imminent. So in that first patient, in the hypotension series, the one in shock, again, we started by adding epinephrine. We did not decrease the vasopressors until we got an increase in blood pressure by increasing contractility. If you have a patient with poor ventricular function and none of this is working and they're still hypotensive, rather than just continuing to crank up the vasopressors, I would argue that you should probably go on ECMO or put in a VAD. Inotropes are not useful if systolic ventricular function is good. And I'll end there, and that gives us some time for questions. So thank you for your attention. And sorry about the random drawing.
Thanks for your nice presentation, dear Professor Schwartz. I myself enjoyed a lot, and that is very useful lecture. So there are only 2 questions in chat section. The first is, in case 1, could we continue dopamine? Could you tell us your opinion about this?
So again, the goal, what you're trying to treat here is the poor contractility, and you actually want to get to a point where you can give vasodilators. So I don't see much value in dopamine. And there's a lot of literature that's come out that suggests that, low dose dopamine for renal perfusion, for example, is more of a myth than a reality. We actually published a paper from here a while back. This was looking at Norwood patients, but we looked at the hemodynamic effects of dopamine and found that it increased oxygen consumption without doing anything particularly useful for cardiac output. This is my personal preference. I mean, again, the absolute drug doesn't matter, but if you want to know my own personal practice, I always teach my fellows that dopamine is the inotrope for people who don't really need an inotrope, at least in the cardiac population. I can't speak to the septic shock population or things like that, but I use dopamine a handful of times every year. Mostly I use it, let's say somebody gets a test dose of captopril and their blood pressure goes down more than I'd like, or they get a dose of lorazepam and their blood pressure goes down more than I'd like, but they're not particularly sick. But I mean, and I really try not to just treat numbers, but sometimes, you kind of have to make it a little bit better. So I might put them on 5 mics of dopamine for an hour or 2 until the drug goes away and then get rid of it. But I don't, if I really think a patient is sick, I tend to use epinephrine, norepinephrine.
Thank you. And the second one is, in which cases milrinone administration is superior to dobutamine? Could
I
you
don't know
please
that
tell us your points of view?
Yeah, I don't know that it is. I mean, again, dobutamine is not a drug we use very often. It probably has a little less vasodilator properties. So if you're really worried about blood pressure and you just want the contractility, I mean, the thing is, I tend to use norepinephrine at 0.02 to 0.05 mics per kilo per minute in that situation. You could use dobutamine instead. Dobutamine also tends to generate a bit more tachycardia, at least in my experience. So I tend not to be crazy about it for that reason. But there are institutions that use dobutamine instead of milrinone, and their results are fine. I don't think there's necessarily a compelling reason to use one versus another. A couple of years ago at a meeting, I had to do a debate against somebody. I had to argue for milrinone, they argued for dobutamine, and I'm not sure either one of us convinced anyone in particular that one was better than the other.
Again, thanks.
Sorry, I have a question. Sorry, sir. I'm Dr. Aghai. I'm pediatric cardiologist in Tehran University of Medical Sciences. I'm too honored to meet you, and I have a question for a patient that is in our ICU with the acute heart failure. What is your preference for the initiation of the drug therapy for this patient? This is a patient that needs to go under inotrope therapy. Okay. In the first line, is your preference goes for the afterload reducing agents and then go for the inotropes? What is your approach towards these patients?
Our approach is usually to start milrinone first. If we're really worried that they're incredibly fragile, we tend to start it at an infusion as opposed to loading them. If there's a little bit more leeway there with the blood pressure, we'll load them. But milrinone is usually our first drug. If their blood pressure is on the high side, even though their perfusion is poor, we'll pretty rapidly add nitroprusside or other drugs to potentially try to bring the blood pressure down, especially if their blood pressure is good, or if they have pulmonary edema, we'll always give a dose of Lasix. And that's kind of our first, that's what you're going to get in the first half hour you're in the ICU with us. Depending on how you respond to that, will determine what we do next.
Okay, and is there any place for the dobutamine in your approach? Is there any place for that?
Again, we would use, if the patient is really in shock, we'll use low-dose epinephrine instead of dobutamine, but that's our institutional preference. But I can't tell you that it's inherently better.
So can I say that the first aim of therapy of these patients would be lowering the afterload of the diseased ventricle, other than increasing contractility of that ventricle?
Well, milrinone will do both, so that's why we do that. I will tell you that, for patients in acute heart failure, who have cardiomyopathy or myocarditis, it seems to me that the clinical improvement that you see when you start a drug like milrinone is much, much more than any improvement you actually can ever measure by echocardiography and contractility. It's not like the ejection fraction goes from 30 to 50, right? The ejection fraction usually doesn't change and the patient looks a lot better. So, that would suggest to me that a big piece of what's happening is in the SVR side of it, that it's not the contractility side. The only thing that I'd say is the blood pressure, well, it depends on exactly what happens. If the blood pressure changes, it can, you may be having contractility changes that are masked by changes in afterload. But this is, again, just personal practice. I don't have any data to support it. First of all, I think milrinone is not a good antihypertensive agent, but it is a good vasodilator in a situation like this. If you really have hypertension, you're going to need to add something else. But I find that, having done this a whole bunch of times, patients almost invariably get somewhat better within the hour after starting milrinone. So.
These are the questions that my friends and colleagues in the ICU just told me to ask you about the the process, the process of the improving patient. How can we دنبال کردن چی میشه خانم دکتر؟ How can we follow the improvement of the patient? Do you prefer to follow the patient with the serum lactate, or do you suggest something else for us to do? For example, echocardiography items or something like that?
So we do a whole bunch of things because, as you know, we don't have any single one measure of adequate oxygen delivery. I mean, for as much as we think we understand about all of this, the fact that we've never been able to really assess that in a totally reliable way is a huge limitation. So we do everything, you know, we have, if you're that sick, you're going to have an arterial line, you're going to have a CVP line. We monitor mixed venous set, lactate, near-infrared spectroscopy of the brain and the flank area. You know, there you sort of, and then you examine the patient as well. And if they're old enough, you ask them how they're feeling. And we integrate all of that information to make an assessment. I actually think echocardiography is probably one of the least useful things, simply because, like I said, the echo often doesn't change even though the patient feels better.
Thank you very much.
We still check the echo from time to time, but for example, I had a patient, I was on call last Friday night, and I had a patient come in shock. It was a tachycardia-induced cardiomyopathy. We obviously treated the tachycardia, a different kind of patient than what we're talking about here, but treated the tachycardia, used milrinone, a little bit of Lasix, and then, you know, we had our first echo on Friday night. We didn't get another echo until Monday because the patient was doing well, and it wasn't going to change. You know, we wanted to wait and see if controlling the rate improved things, and we wanted to give it a couple days for that to happen.
Thank you very much. Dr. Memar?
Thank you for sharing your knowledge with us. We are so glad to have you with us. So we will continue with dear Dr. Ajay. Good evening, Dr. Ajay. We are so honored to have you with us. Dr. Ajay, can you hear me?
Yeah, I can hear you. Good evening.
Good evening. We are so honored to have you.
So I'll share my screen and let me know.
Sure.
Yes.
Sure.
You can see my screen?
Yeah.
Yes, we are all ears.
First of all, thank you for having me. I would like to start by thanking Prof. Schwartz with the first talk, which was excellent. I learned quite a lot, and most of our clinical practice, you know, we match, and I was pleased to hear some of his views, which we also share. So today, my talk is on eCPR in pediatric cardiac patients. I come from Royal Brompton Hospital in London. So our hospital offers a vertical model. We look after neonates, infants, children, adolescent population, as well as adults. So we have adult and pediatric teams, and I work in pediatric intensive care. So no financial disclosures. I would never start a talk on ECMO without showing Prof. Bob Bartlett, who invented the magic therapy of ECMO in 1972. He was the first one cardiac surgeon from Michigan. He put the baby with meconium aspiration on ECMO. That baby is now called Esperanza. She is now, I think, 48 years old, healthy and alive. So what are the objectives of my talk? I will briefly touch upon the evolution of definition of eCPR. We'll outline the magnitude and what are the trends of eCPR in children. How do we manage cardiopulmonary resuscitation before putting the child on ECMO? And what are the key principles of managing the patient on ECMO following CPR? And I will briefly touch upon eCPR outcome. So the definition of eCPR has evolved over last 10 to 15 years. Some time ago, ECMO cannulation during active CPR with chest compressions was considered to be eCPR. That means active chest compressions should be ongoing and you actually cannulate the patient. Only then it was considered to be eCPR. Then over a period of last few years, the inclusion of return of spontaneous circulation that was added into the definition. So eCPR is the application of rapid deployment of ventricular arterial ECMO to provide circulatory support in patients in whom conventional CPR is unsuccessful in achieving sustained ROSC. So what do we mean by sustained ROSC? That is when chest compressions are not required for 20 consecutive minutes and signs of circulation persist. The reason I'm highlighting the definition of eCPR is I think it is important to have a consistent approach across not just one center, but across multiple centers across the country or even beyond the nation approach. So it is important to have a standard definition, and then this will help in long term in assessing the outcomes. So if you look at the neonatal eCPR, over the period last 10 to 12 years, the neonates receiving eCPR has gradually increased, but maybe has kind of plateaued in the last 3 to 5 years. As opposed to pediatric eCPR, the number is gradually increasing. I think this reflects the confidence of ECMO centers across the world. Perhaps 10 years ago, ECMO was more limited to American, Canadian, and Europe centers. But in the last 5 to 10 years, I have seen colleagues across the world doing more and more successful ECMO runs. So let's move to cardiac patients. The cardiac arrest in pediatric cardiac patients, the incidence is around 0.7 to 2.9%. The good news is that the higher incidence of reversible causes and up to 79% survive to hospital discharge. So what do we mean by reversible causes? So it could be, for example, ventricular fibrillation. It could be a blocked BT shunt. It could be a large pleural effusion or pericardial effusion, or it could be acute myocarditis. And there will be, I have seen there are talks following my talk on cardiopulmonary interaction. So all of these are sometimes reversible. So the prognosis is slightly better in pediatric cardiac patients. So we need to understand peri-arrest physiology. The current CPR algorithms do not fully address cardiopulmonary cerebral interactions. There is often a lag period between the research updates and implementing them within an intensive care unit. If you look at the standard CPR algorithm, it just dictates what exactly needs to be done at what interval. So in other words, this algorithm is quite static. So if you look at the adult VF model, this model predicts 50% survival rate for defibrillation in the electrical phase. So when a patient goes into VF, for the first 0 to 4 minutes, it's mainly electrical phase. So if we provide a shock, it will have a much better impact on the outcome. Then beyond 5 minutes, what happens is because of poor coronary circulation, shock may be less effective as a first-line therapy. So between 5 and 10 minutes, it is better to perform CPR first, restore circulation, and then provide a shock therapy. And beyond 10 minutes, there will be tissue hypoxia, and then adrenaline may be less effective. If you consider, for example, pulseless electrical activity, it also goes into various phases. You can have normotensive pulseless electrical activity, wherein the function of the heart may be okay, but it is more because of extrinsic factors, for example, pericardial tamponade or tension pneumothorax. Then in pseudo PEA, although one may not be able to feel the pulse, if you look at the echo, there could be still pulsations at the root of the aorta. Then if these conditions persist, then the patient goes into true PEA with prolonged acidosis and hypoxia. So what are the key challenges in pediatrics? I have seen in adult intensive care units how they do chest compressions. They got beautiful automated machines which will provide effective chest compression. But children come in all sizes, and unfortunately, we do not have that luxury of providing effective chest compression. And sometimes when chest and abdomen can be open after a pediatric cardiac surgery, we can imagine performing effective CPR is quite challenging. Also, when pacing wires are placed after a cardiac surgery, it is relatively easy, but occasionally if pacing wires are not present or if they have been removed and the patient goes into heart block, then one can imagine how tricky it can be. So why we should offer eCPR? The overall survival from in-hospital cardiac arrest and CPR has remained less than 30% over the last 50 years. This gets worse with out-of-hospital cardiac arrest, where the outcomes have been less than 20%. A simple rate comparison between range of CPR survivorship and the survival rate found in meta-analysis. When faced with a cardiac arrest, the ECMO use may have an added value of 12 to 23% on the survival rate. So there is a clear case why we may offer ECMO in the setting of cardiopulmonary resuscitation. What are the advantages of ECMO in a post-resuscitation period? It will be far easier for us to titrate the physiology. We can improve the organ perfusion. We can restore acid-base balance. We can focus on oxygen delivery and CO2 clearance, and we can maintain temperature. The other important reasons are we can allow myocardial rest and also minimize the intensity of mechanical ventilation. So what are the key strategies for eCPR? The first and foremost is patient selection. We'll go through all these one by one. Patient selection, effective CPR. We need to reduce the duration of CPR. ECMO management tailored to physiology. We need to identify and treat the underlying cause. We need to prevent or minimize ECMO complications. And finally, but not the least, manage expectations and having an exit strategy. So what about patient selection? In an ICU, occasionally patients do suffer cardiac arrest. But if you look back, sometimes there'll always be some signs that would tell us that this patient is a high-risk patient. So what we normally do in our unit is every day in the morning, we do what is called as anticipatory care. We identify patients, and if they are extremely high risk, we may have an ECMO circuit standby. It also alerts surgeons and perfusionists, for example. I don't know how other centers operate outside UK, but within UK, we do not have 24/7 perfusionists on call. So it takes at least 30 to 40 minutes time for the perfusionist to arrive to the ICU out of hours. So it is always better practice to identify high-risk patients. Other things about patient selection is you need to see are there any conditions precluding effective CPR? Is it an unwitnessed cardiac arrest? And what do parents think? Sometimes parents may not want this child to go on ECMO. It may be a futile exercise. So imagine certain conditions where if you have a severe AV valve regurgitation, and if you try to provide cardiopulmonary resuscitation, the cardiac output during CPR may not be enough because of severe AV valve regurg. Similarly, if you have a blocked BT shunt, unless you open the shunt, it is very hard to perform an effective cardiopulmonary resuscitation. You're simply not going to get any oxygen, blood, and cardiac output. Another example is Al-Kappa, which is again notorious for CPR. And finally, if it's a Fontan patient, I will address that later in my talk. Again, a very high risk patient for cardiopulmonary resuscitation. So what about effective CPR? Perhaps in my entire talk, this is probably the most important thing we need to understand. We have to have an effective cardiopulmonary resuscitation for a better outcome when a child goes on ECMO. I do not have to go into detail. It's quite easily understandable. We need to have minimal interruptions during CPR. The technique needs to be good, adequate rate, depth, allowing chest recoil, firm surface. So standard basic ICU care. Key highlight I would like to mention is, if possible, we should convert from external cardiac massage to internal cardiac massage, only in some select cases. Avoid excessive ventilation, avoid excessive adrenaline, perhaps. This is a controversial area, and we need to monitor the quality of CPR. So we published how we can improve team training through simulation. Here we have a student from Australia who was visiting us. We allowed him to practice CPR on a mannequin, and this mannequin actually monitors, and it can give us an indication how effective is the CPR. So in the first attempt, he placed his hands in an improper location. It was not ideal. So the effectivity was something like 47%. And then we corrected his hand placement technique. His efficacy improved to 76%. And finally, after demonstrating another attempt, he could reach up to 98% efficacy. So the target we usually look for is more than 85% of the time, you need to be providing effective chest compressions. Another important feedback we had from this guy, he is a well-built guy, and after 2 minutes, he was actually very tired. He said his hands were shaking. So that shows performing effective CPR is energy consuming. Then hand-bagging technique, very important in children with cardiopulmonary resuscitation. I'm sure in the next talk, this will be covered, but make sure you do not overinflate the lungs during cardiopulmonary resuscitation. This will severely impact cardiac output. So where possible, we convert external cardiac massage into internal cardiac massage. The cardiac output significantly improves with internal cardiac massage. There is also bigger improvement in the coronary perfusion pressure, but it comes with a health warning. If you're not trained in doing internal cardiac massage, it is best to avoid that. There are different methods in pediatric cardiac patients. Sometimes closed chest compression is not always possible to perform CPR. So when a chest is open like this, you can do a circumferential chest compression. If you have an arterial line, you can monitor the efficacy of your chest compression. It is important to reduce the total duration of CPR. There is evidence which shows the longer the duration of CPR prior to going on ECMO, the outcome gets worse. So it is important to have a structured guideline and protocol. We need to mobilize the team early. It is important to remember eCPR is a major team work. So all the team members need to be there, the theater, the surgeons, the perfusionist, and the ICU. So you need to have a structured approach in your unit. As I mentioned before, if you anticipate a high-risk patient, you can have a pre-primed circuit. And also in an older child, femoral cannulation using 2 surgeons, it will significantly reduce the time to cannulate the patient. So CardioHelp we use for children more than 30 kilo weight. I'm aware that in US, CardioHelp machines are there even for smaller children, but in UK, the lowest is around 30 kilograms. The advantage of CardioHelp is the cannulation time and the priming of the circuit is much quicker. Within 10 minutes, you are ready to go. And it is important to monitor effectiveness of CPR. So you can use bilateral NIRS. So here you can see on the left-hand side, the CPR is going on and the child is placed on ECMO and gradually the NIRS improves. End-tidal CO2 is again another effective way of monitoring CPR quality. And also arterial line, if it is present, it is very helpful. So cannulation in CPR is usually ventricular arterial cannulation. It can be either central, where if the chest is open, the surgeon, all he needs to do is take out the membrane and cannulate, or it could be peripheral cannulation, either via the neck or the groin. The advantage of peripheral cannulation is it leads to uninterrupted chest compression. In in univentricular heart, you may need to think of hybrid configurations. So once the child is on ECMO, we normally go for physiology-based approach, prevent hyperoxia, avoid hypocarbia, and avoid hyperthermia. We tend to focus on the expected saturation for the underlying physiology. If the underlying physiology is a biventricular physiology, we go for normal saturations and PaO2. If the underlying physiology is a single ventricle, then as per whether it is post-Norwood or post-Glenn, then accordingly we titrate our expectations. The target saturations need to match the underlying physiology. All in all, we keep it simple: normoxemia, normocarbia, and normothermia. In a cardiac ECMO, we need to focus on LV decompression, focus on afterload reduction. It could be left atrial vent or atrial septectomy or septostomy. Remember, venting of the left side may not be necessary in all patients. Sometimes we do not know what exactly happened, why the child had a cardiac arrest. This is a 2-year-old child out of hospital cardiac arrest, ventricular fibrillation. The ambulance crew shocked the patient and brought the patient to our ICU. When the patient was admitted, the patient kept having repeated episodes of VF and multiple brief episodes of cardiac arrest. So went on ECMO straight away. This is the first X-ray, massive pulmonary edema. The second X-ray was after left atrial decompression, doing atrial septostomy. But we still did not know what was the underlying cause. So the child underwent cardiac catheterization. Here you can see the coronary ostial narrowing. So this child actually had coronary ostial stenosis, which was ballooned. So it's important to treat the underlying cause in an eCPR. What about eCPR in a Fontan circulation? This is extremely challenging. There is a mismatch between coronary perfusion and cerebral perfusion. There is no subpulmonic ventricle. That means in a normal heart, when we do chest compression, the blood from the right ventricle goes into the lungs, comes back into the left ventricle, and it goes forward through the aorta. But in case of Fontan circulation, the venous blood has to enter directly into the chest cavity. So when we are doing chest compression, it actually doesn't improve uh, the pulmonary blood flow. So this is a very tricky situation. Um, and if at all there is moderate to severe AV valve regurgitation, my personal suggestion would be not to attempt ECPR because it will be a very futile exercise. Human factors is critical in an ECPR scenario. As I mentioned, it is a teamwork. It is not one person's job. It is a crisis. So it needs leadership. It needs clear role allocation. It needs clear communication. And someone needs to step back and lead the scenario. So I'm sure many critical care units have this picture. Normally, what we do is we allocate at least 2 to 3 people just to provide continuous chest compression to maintain effective ECPR. And we assume a dual leadership role. You can see here 2 people standing at the foot end. What do I mean by dual leadership? Normally, when only one person is leading, sometimes it may be too much to take on. So what we do is the medical lead usually focuses on the CPR, and the nurse lead focuses on organizing all the team members, like organizing the theater team, calling the perfusion, making sure all the drugs are administered as per the protocol. And usually there is one person just to monitor the quality of CPR. The outcomes in neonatal as well as in pediatric survive to discharge is around 42%. In Brompton, over the last 9 years, we had 44 ECPR cases with 26 surviving to discharge. So overall survival rate was 59%. So here is a survival outcome after ECPR following in-hospital cardiac arrest. This paper shows that children with isolated heart disease have a better survival outcome. Children with underlying other medical conditions, the survival rate drops significantly. So here is another paper that compares conventional CPR versus ECPR. In the conventional CPR arm, the survival to discharge is around 27%. In the ECPR group, it is around 40%. And favorable neurological outcome is around 18% in the conventional CPR group, and favorable neurological outcome is up to 27%. So ECPR not only improves survival to discharge, but it also has better neurological outcomes compared to conventional CPR. This is another paper that had combined the analysis of merged data between ALSO and AHA Get With the Guideline Registry, 32 hospital over a 15-year period. They looked at all children with in-hospital cardiac arrest who went on to ECMO. And what this paper clearly showed is pre-existing renal insufficiency prior to going on ECMO. It was an important variable. And once the patient is on ECMO, renal or pulmonary or neurologic complications further increased the odds of death ratio. And as the number of complications increase while the child is still on ECMO, the odds death ratio increased significantly. What's the prognosis for ECPR? I would say it is best to not go on ECMO at all, if that could be our wish. But unfortunately, children do suffer cardiac arrest in ICU. eCPR is definitely better than conventional CPR. But what I would push the team is, sometimes eCPRs could be anticipated and they could be put on elective ECMO. The classic example being a child is coming back from theater on high dose inotropes. Sometimes the dose of inotropes is so massive, people might wait too long before the child has a cardiac arrest. So try and avoid a cardiac arrest. If possible, go electively on ECMO. That's much better scenario. I used to believe neonates favor less compared to children, but unfortunately the data doesn't prove that. Univentricular heart eCPR is definitely, children have worse prognosis. Again, longer duration of CPR, ineffective CPR, comorbidities, and complications whilst on ECMO. They all add to the poor prognosis. So to conclude, eCPR is a complex resuscitation event. Patient selection and effective CPR is vital. When on ECMO, avoid early reperfusion injury, that is preventing hyperoxia. Isolated cardiac patients have better prognosis. Interprofessional team training is integral to effective CPR program. So this is my last slide. It just shows that eCPR is a complex interaction between patient, the teams. It tests the ICU system, and it involves a massive amount of training. And effective CPR is the base for a better outcome in the case of eCPR. Thank you. And any questions, please?
Thank you very much, Dr. Desai, for your nice presentation. We have just started to have ECMO in Iran. We have not developed it, but it's a beginning of ECMO in Iran, and your lecture was very useful for us. Thank you very much for the time and for the effort you had for this presentation. And I also should be very grateful to Dr. Bahar Azadi, who have introduced us to you and help us in inviting you to our Congress. Thank you very much.
Thank you. Thank you for your kind invitation. And Bahar was
thank you very much.
Yeah.
Oh, my pleasure. I was really enjoying the talk. Thank you so much, Dr. Desai, and thanks, Behta.
Thank you very much. Thank you very much, Dr. Desai. Thank you very much, Dr. Azadi. Also, Dr. Mohsenibot helped us in having many of our lecturers for this Congress. Professor Schwartz has also been invited by him, by Dr. Mohsenibot. And we were supposed to have the lecture of Dr. Alejandro Flo from Sick Kids Children's Hospital in Toronto, but he couldn't attend attend himself. But we had his recorded lecture on PowerPoints. Unfortunately, we cannot open and play his presentation, so we will have another lecture from one of our other lecturers that will be introduced to you. Thank you very much.
Dear Dr. Desai, thanks for your educational lecture and for sharing your insight with our audiences. Because of the shortage of the time, we will ask the question in chat section. So we will continue with dear Dr. Ayesha Akjan Arikan, Associated Professor of Pediatrics, Renal and Critical Care Section, Baylor College of Medicine, Texas Children's Hospital. She talks about acute kidney injury in pediatric heart failure.
2 ve 1 sizinleyiz hocam.
Well, thank you very much to the organizers for this kind invitation. It's a pleasure for me to participate in this exciting session. My topic today is acute kidney injury in pediatric heart failure. The slides are not advancing. Let me try from here. Okay. These are my disclosures. I don't have anything pertinent to this presentation. So what we're going to do today is that we're going to review the definitions of acute kidney injury in heart failure. And even though there is a fair number of groups who might be at risk for acute kidney injury, we're going to focus on acute decompensated heart failure today. We're going to go over pathophysiology very quickly, then delve into a little bit what diuretic response versus diuretic resistance means, and then try and differentiate between worsening renal failure versus acute kidney injury versus the progression or the continuum between acute kidney injury and chronic kidney disease. First off, who's at risk? So there is the topic for this talk is acute kidney injury and heart failure, but in pediatrics, heart failure can take a number of forms. Obviously, very pertinent to our specialty is the congenital heart disease and the infants and the children who undergo surgery for either the correction or palliation of congenital heart surgery. This is referred to as cardiac surgery associated AKI because it is typically related to the cardiopulmonary bypass and associated pathophysiology. It is very nicely studied in the literature since we can tell when the actual risk or the onset of injury for the kidneys is going to be. But what we're going to focus on today is the patients who will have acute decompensated heart failure. And I'm going to refer to it as heart failure going forward. So if you look in the literature, the definition for this is quite nebulous and frequently decided on by the investigators. But there's a big quality group in cardiology and cardiac critical care that has been organized in the last few years here in the United States. The PC4 group, this quality group, aims at standardizing certain approaches across the population and also understanding the behavior and the management of the patients better. The PC4 defines heart failure as documented systolic and or diastolic ventricular dysfunction and at least one of the following: either vasoactive use and or diuretic use, or respiratory support, and it can be anything from high-flow nasal cannula to invasive mechanical ventilation, or mechanical circulatory support in the form of ECMO, ventricular assist device, implanted or paracorporeal devices, any of them. Obviously, this last group is a specific vulnerable group for acute kidney injury in and of itself because of multiple risk factors that pertain to the way the device actually supports the body. And then another group that we're not going to spend much time on, any time on today, but we need to bring up is the patients who undergo heart transplantation. They're at high risk for AKI. What are the available renal function measures in any of these groups? Obviously, we have the most available, least expensive, and easiest functional measure, which is urine. And the patients who make less urine are going to be the ones who are going to be diagnosed with AKI based on the current consensus criteria. Then we have filtration markers. Creatinine is the one that is universally used, but there is cystatin C as well. This is plasma cystatin C, which is actually coming into light recently as maybe a little bit better and earlier filtration marker in terms of diagnosing AKI. However, it's expensive and it's not readily available in all centers. And then there is these damage markers, which we used to be called novel biomarkers, which are secreted or upregulated or released by infiltrating inflammatory cells in the tubules. We're not going to spend any time on these today because these are largely of research interest still and have not really penetrated clinical use very widely. So in order for a marker to actually be used to measure renal function and gauge renal dysfunction, it needs to be either filtered across glomerular basement membrane and then not reabsorbed and get spilled in the urine, or it should be constitutively or when triggered induced molecule so that it actually can be picked up and detected as an insult, or as we alluded to, it will come from the infiltrating immune cell molecules, because AKI in and of itself, even when triggered by ischemia and reperfusion, is largely an inflammatory disease. I am going to propose to you that we don't actually know how to define acute kidney injury in the pediatric cardiac population, and I'll tell you why. If you look at the literature, there's a wide variance in incidence from 10 to 15% to over 50%. This depends on the population, but also on the definition that is used to define AKI. If it's not done per protocol, RRT need is not really more than a few percent, not more than 5%. RRT meaning renal replacement therapy. Oliguria is not a rigorously tested AKI marker in this patient population, and some increases in serum creatinine actually might not necessarily pertain or point to kidney injury, and we'll see that in a second. This is the standardized available pediatric AKI definitions, KDIGO, and then the older definitions of pediatric AKIN and pediatric rifle on the right of my screen. So what we gauge it by is either by relative increases in serum creatinine compared to a patient's baseline, or increasing durations of oliguria. Now, this oliguria is going to come back to us as a prognostic marker again and again, and we'll dive deeper into that in a second. But what I'm trying to show you here is that depending on which definition you use, and this pertains to both acute kidney injury and heart failure, if we're not really using the consistent definition across patient groups, then we might actually be talking about different physiologies, and we're not really going to be able to understand the true burden of the disease and make a meaningful difference. Here's an example. This is a hot off the press, very recently published from the quality database that I was alluding to, PC4. 23 centers contribute to this database, and these investigators looked at almost 27,000 admissions, and teased out the heart failure admissions, almost 1,500 of them. A little over half of them were due to congenital heart disease, and the rest were due to cardiomyopathy and other diseases. They looked at outcomes of these children, hospitalized children, and even though AKI definition was not standardized, they reported CRRT use. 3% of all encounters had CRRT, so very small group at risk, you would think. But mortality was significantly higher in patients who had CRRT, 11% compared to the others, which is 2%. In fact, CRRT mortality in the ICU was even higher. So patients who required renal replacement therapy and were in the ICU actually had higher mortality. But when we looked at hospitalized heart failure patients and used the standardized AKI criteria, we showed that depending on which definition is used, 1/3 to 2/3 of patients all have cardiorenal syndrome or acute kidney injury. And not only do they have AKI on admission to the hospital, they also actually have worsening renal function throughout their hospitalization. And some of them even get discharged from the hospital with still impaired renal function. So then what is cardiorenal syndrome? I'm going to propose I'll say this is an age-old concept, understand from a mechanistic standpoint. There is two big, broad categorizations, or three rather, but the third one we're not going to deal with today. There is the paradigm where cardiac failure leads to renal injury, and then there is the paradigm where the renal loss or kidney injury, kidney failure leads to cardiac failure. And then broadly, we put them into acute and chronic groups, and we talk about type 1 and type 2 cardiorenal syndrome. Let's zoom in on that a little bit more. This is acute cardiorenal syndrome, where you have a cardiac event, either surgery or heart failure or worsening heart failure or cardiogenic shock from some other, maybe an arrhythmia process. And then through a number of pathways, there is the downstream consequence on the kidney, where we have acute kidney injury. The chronic cardiorenal syndrome is where you have chronic heart conditions with cardiomyopathies, valvular diseases, single ventricle pathways. You can give a number of examples here: Kawasaki's disease and coronary artery involvement and subsequent cardiac failure. And then again, a number of pathogenic mechanisms in play that lead to acute kidney injury, and then the acute kidney injury leads to remodeling, apoptosis, fibrosis, and progression to CKD, chronic kidney disease. And here's the paradigm of how this would happen. So decreased cardiac output, low cardiac output state from any condition is going to lead to a number of compensation pathways, which are initially meant to increase the effective circulating volume by causing renal sodium retention and water retention and restoration of the cardiac output. However, over time, this process becomes maladaptive and the kidney is actually congestion state itself. So heart failure feeds into kidney injury, but kidney injury will also feed into heart failures. This is a bidirectional phenomenon. There is not only these maladaptive, adaptive, and over time maladaptive mechanisms that we talked about, but there is also the downstream consequences of them that are important. Some of the medications that are used for treatment of heart failure might actually have inadvertent detrimental impact on the kidney function itself. And fluid overload is, of course, very important consequence and also a predictor of adverse outcomes. And obviously that relationship is not as simple as I made it into a schema there. There is many other different complicated systems in place. And each of these have been very eloquently studied in adult heart failure, but not as thoroughly in pediatric heart failure. The first group that actually proposed worsening renal function as an indicator of a pediatric cardiorenal syndrome was Dr. Price's group from Texas Children's Hospital. And he showed that in patients who were hospitalized with heart failure, the ones who had worsening renal function, denoted by WRF, had much worse outcomes in terms of dying or needing a mechanical circulatory support endpoint, such as that. And the 0.3 milligrams per deciliter increase in creatinine seemed to be a good hinge point where the predictive ability of requiring increased support or not responding to any treatment and succumbing to the disease became a good predictor. And this paradigm has been repeated. The 0.3 milligram per deciliter increase in creatinine has been repetitively used in pediatric literature to actually look at renal function in the context of cardiorenal syndrome. What is when we alluded to and talked about worse congestion leading to worse AKI, I am presenting to you a very eloquent adult study. Here, there is 4 panels. There is central venous pressure, there's cardiac index, there's systolic blood pressure, and pulmonary wedge pressure. And as we go from left to right, from dark to lighter, we actually have changes in each parameter that is indicated here. So increasing CVP, increasing cardiac output, increasing systolic blood pressure, increasing wedge pressure. What will immediately catch your eye is that on the y-axis is worsening renal function as determined by percentage of decreased GFR. The only appreciable change that we see here is with increasing CVP. In fact, CVP is the predictor of worsening renal function, whereas cardiac index, whether it's high or low, basically has an area under the curve of 0.5, so like a coin toss. And here it's a little bit better, maybe granularly presented. Here we have high cardiac index and high CVP. Here we have low cardiac index and high CVP, yet this high CVP group has the lowest GFR regardless of where the cardiac index lies. We demonstrated this in a pediatric group and pediatric and young adult cohort, where we looked at patients palliated with Fontan circulation, and the ones who actually had higher Fontan pressures as a surrogate for filling pressures for CVP had much lower GFR at follow-up, even though they were slightly older. So perfusion pressure in the kidney is the difference between mean arterial pressure and the central venous pressure. As the CVP is increasing, or if there is significant ascites, if the intra-abdominal pressure is increasing, you will easily see that the perfusion pressure is going to get impacted significantly. Hence, worse congestion is going to lead to worse kidney function. And this is not only just important in the acute setting, right? At the very top, I'm showing you, this is a cardiac surgery-associated AKI and the resultant fluid overload paradigm, but can easily be applied to heart failure. Acute fluid overload leads to a lot of depressed organ function, impairs wound healing, decreases pulmonary compliance, actually worsens heart function itself. But then it has long-term consequences in terms of repetitive AKI leading to chronic kidney disease and the associated disability and death that comes from this condition. So when we looked at patients who we hospitalized for acute decompensated heart failure, we identified over a period of 5 years, 75 pediatric patients who were hospitalized with heart failure. And we looked at their cardiorenal syndrome measured by standardized AKI criteria, Aiken, KDIGO, and P-rifle. And of these 75 patients, 25 failed medical therapy and either required a heart transplant or a VAD or die. And what we showed was that P-rifle was more sensitive at admission in detecting their CRS. And regardless of whether we detected it with Aiken or P-rifle, more patients actually went on to develop CRS throughout their hospitalization. Interestingly, regardless of whether they actually had CRS on admission or did not, and this panel is P-rifle and this panel is KDIGO Aiken, and you will see by P-rifle, 2/3 of the cohort had CRS already on admission. By KDIGO Aiken, 1/3 had CRS on admission. Even the ones who did not have it went on to develop it in a majority of the cohort. Now, this is a sick group of patients, and obviously part of this is going to be their progression of kidney disease. But part of it might be some of the treatments that we're doing, and it's a little bit difficult to understand how this relates to in terms of decongestion. So diuretic use is ubiquitous in congestive heart failure, right? So, and the most importantly used diuretics are loop diuretics. And the loop diuretics are used to actually decrease this renin-angiotensin aldosterone system activation, and the sodium retention that is used initially as compensation, then as maladaptive. It treats this endpoint. But loop diuretics contribute to the upstream steps here. They actually precipitate arterial underfilling in overdiuresis, and they themselves might actually activate renin-angiotensin aldosterone system. Therefore, over time, there is this concept of diuretic resistance that might happen with overdiuresis, and multiple strategies are used in the clinical setting, not very rigorously studied in the pediatric group, with sequential use of diuretics, where thiazide diuretics are used in the distal part of the nephron in order to block sodium chloride absorption there, or for the secondary hyperaldosteronism, aldosterone antagonists could be used. The Lasix response in terms of diuresis is quite important in all patients who have heart failure, as you would guess. In fact, in this one study where after cardiac surgery, where investigators tested diuretic response to Lasix, at 2 hours and 6 hours, the patients who actually did not respond to a Lasix dose were more likely develop AKI during the study period with pretty decent predictive power, area under the curve of 0.74 to 0.77. And the paradigm of not responding to diuretic resistance is changing, or not responding to diuretics is changing a little bit in pediatrics and also in adults. It's the diuretic resistance concept is being turned into this diuretic response, a quantifiable, easily available clinical tool to be able to actually gauge the response of the patients in real time and appropriately titrate their treatment. Now, this is usually defined as weight loss per 40 milligram of furosemide or equivalent. This is an adult definition. And it is measured in net fluid loss per milligram of loop diuretic agent. Because decongestion is the keystone of heart failure management, this is quite important to be able to actually assess in time. However, the heart, like we talked about, the diseased heart operates on a very narrow spectrum of safety. So while fluid overload is detrimental, so is underfilling from overdiuresis. We tried to look at this diuretic responsive concept in pediatric patients with heart failure, took patients less than 21 years of age who were on loop diuretics for 72 hours and converted all of their loop diuretics to furosemide and measured their net fluid output per milligram of loop diuretic. We divided patients into high responders and low responders. Low responders were younger, were less likely to have overt fluid overload or congestion, and were actually had higher estimated GFR. The patients who had high diuretic response had better outcomes in terms of not requiring renal replacement therapy or having worsening renal function, and were older and had obvious evidence of congestion on both physical exam and chest x-rays. Each decrease in diuretic response was associated with a 3% increase in mortality or mechanical circulatory support need. But at 72 hours, 34% of the patients had more IV fluids in than out. And these are patients admitted for decongestion. In fact, you'll see both the high responders and the low responders had 37 to 54% had IV fluids prescribed to them. This is a pervasive phenomenon where we don't actually pay attention to how much fluid the patients are taking in. In a group of cardiac surgery patients, the actual urine output was never really at oliguric levels, but the fluid intake was either not reported, or when it was reported, it was quite higher than what would be considered normal fluid intake that should be prescribed to these vulnerable and quite fluid sensitive patients. And in fact, in a pediatric cohort of PD catheter use, peritoneal dialysis catheter use, where the use of peritoneal dialysis catheters were associated with improved fluid management, the patients who actually did not have PD catheters and were controls ended up having much more fluid exposure than the patients who had a PD catheter in. So it really matters what's happening to the patient. Is this actually a prescription error, or is this an obligate fluid management, fluid intake that is driven by the need for multiple medications and the vehicle used for it, which is fluid? But the concept of whether this is diuretic resistance or cardiorenal syndrome challenges every clinician on any given day who is taking care of these patients, because the end product looks very similar, both in worsening heart failure and diuretic resistance and cardiorenal syndrome that is evolving because of overdiuresis or underlying kidney injury. This is a quite important point that I'd like to make. So this is a very elegant study from adults, but I think it has implications for us too. So we all know that decline in renal function with decreased estimated GFR is associated with higher adverse outcomes, higher risk for adverse outcomes. In fact, here I'm showing you adjusted hazard ratio for death, and this is decline in GFR, and it shows increased risk for mortality. Whereas decongestion, successful decongestion with hemoconcentration where BMP decreases and hematocrit decreases is associated with improved survival. But when we combine these things together, and when we look at markers of decongestion with decreasing BMP and increasing hematocrit, the differential of the estimated glomerular filtration rate decline on the impact of death is very different. Here, we have not much decrease in BMP and not much increase in hematocrit, and the decreased GFR is associated with increased death. However, when you have successful congestion and successful decongestion and hemoconcentration with decreasing BMP and increasing hematocrit, GFR decrease stops being independently associated with increased mortality. Hence, it really needs to be evaluated in the context of the patient at the bedside. It cannot be driven by just one biomarker alone, whether this is renal function, BMP, or markers of hemoconcentration. There is the concept of worsening renal function or diuretic resistance being an indicator for worsening renal function in pediatrics. In patients who actually required mechanical circulatory support and who had low GFRs when they were being implanted with a VAD, the renal function improves very quickly. However, the improvement might not be persistent in patients. This is a group from Pediatrics, which is patients with implanted VAD, and over time, some patients fail to improve their renal function, and some patients actually have worsening renal function. So clearly, there is two differential mechanisms in play here that need to be teased out on a patient-by-patient basis. We looked at this in our patient population who had a VAD implanted, and it seemed like repetitive AKI episodes actually were associated with the greatest decline. And hence, follow-up of these patients is quite important. I'm trying to show you here, these next three slides are going to be available for you to look through. These are underlining the points that I was making, which is not every patient who has AKI or cardiorenal syndrome or worsening renal function is the same, and clinical picture needs to be taken into account with other indicators with filling pressure, markers of hemoconcentration, and other biomarkers that are available. And I'm going to quickly go through these slides because these are just another reiteration of the point I was trying to make, which is not every worsening renal function or CRS is the same in the clinical arena. So what are our take-home points? This is a quite common condition, AKI, CRS, WRF in pediatric heart failure. Standard definition used will facilitate recognition. Response to decongestion can be quantified with diuretic responsiveness. Successful decongestion is key. If you're not getting where you want, you need to beware of fluid exposure, but it might just be that the patient needs more support. And long-term follow-up due to the evolution of CKD is essential in these patients. And with this, I'm 2 minutes over time, but I'm going to wrap up and thank you.
Okay, thanks to Dr. Aisha Akshan. Unfortunately, we couldn't have her tonight with us. So we'll go to our next presenter, dear Dr. Luciana Rodriguez. Can you, Elmira, go on for the introduction?
Okay, let's start the next lecture by dear Dr. Rodriguez, the Hospital of Sick Children, Toronto, Canada. Good evening, Dr. Rodriguez.
Good evening. Thank you for inviting me. And now I will pause 1 second to share my screen because...
Yes, you are now co-host and you can share your screen.
Okay.
Please.
So I need to put, you may need to guide me.
Okay. You must select share screen on the bottom of your screen.
Yes, I am there. And now?
after that, you should open your PowerPoint.
That's it. That's it.
Okay, and now
Yes.
open my PowerPoint.
Yes, it's okay.
And can you
Yes,
see?
it's okay. Yes, it's okay.
Perfect. Okay, so I will start again by saying I'm very grateful for this invitation. I am one of the newer staff at Sick Kids in the Cardiac Critical Care Unit, and what I will talk today is about cardiopulmonary interactions. This talk has a physiological perspective, so you will see that I will review through the talk a lot of physiological concepts you might be familiar with, trying to understand how we can maximize oxygen delivered by mechanical ventilation. Now that I know that Alex couldn't present today, I will speak a little more about mechanical ventilation. So we will go through the definition of what cardiopulmonary interaction is, and then we will spend a lot of time looking at different heart-lung interactions, and as I told you before, reviewing some physiological concepts, the effect of lung volume on PVR, transmural pressure, afterload as an example of transmural pressure, the difference between RV and LV physiology, what ventricular interdependence is, and the effect of positive pressure ventilation on PVR. We will also very quickly review the distribution of ventilation and perfusion zones, West zones, to finish this presentation with the effect of negative and positive pressure ventilation and PEEP on cardiovascular function, and then specifically in patients with congenital heart disease. So, as you know, in order to understand what cardiopulmonary interactions are, we need to think that the heart and the lung share a common space, that is the chest cavity. The pericardial pressures, and this is very important, reflect intrapleural pressure during the respiratory cycle. Between the right and the left heart lies a highly regulated vascular bed, that is the pulmonary vasculature. Changes in respiratory mechanics impact the loading conditions of the heart, but also changes in cardiac physiology can affect lung physiology. And a very clear example is the consequence of left atrial hypertension with pulmonary edema. On top of that, both has the same aim, that participate in the delivery of oxygen to the rest of the body. So this interplay between lung and cardiac physiology, so that a change in one side impacts on the other, is called cardiopulmonary interactions. Oh, I cannot advance. 1 second, I did something wrong here.
There's no problem. If you can just you cannot change your slides, maybe it's better to stop sharing and then go again for your. Oh no.
I know
okay.
now
it's
how
okay.
with the arrow, but if not, I know what to do. Yes. So what we need to remember that the main difference between spontaneous breathing and positive pressure ventilation is that both of them, when we breathe spontaneously, that means like myself now, or when we have a patient on a ventilator, both of them increase lung volume above end expiratory volume. In normal condition, this end expiratory volume is FRC, or functional residual capacity. The difference between spontaneous breathing and positive pressure ventilation is the way they do this. Spontaneous breathing by decreasing pleural pressure, or maybe some people are more familiar with the term intrathoracic pressure. But positive pressure ventilation increase lung volume in every insufflation by increasing pleural pressure. This has a huge difference in the hemodynamic consequence of decreasing versus increasing pleural pressure or intrathoracic pressures. And this is what we are going to review in a minute. In terms of the effect of lung volume on PVR, we need to remind everybody that the PVR, you can see the graphic. Can you see my arrow as well? Okay, So you have the pulmonary vascular resistance here and the lung volume, from residual volume, functional residual capacity to total lung capacity. So what we know is the lowest PVR occur at functional residual capacity. And this is because the alveolar and extra-alveolar vessels behave differently in different lung volumes. Alveolar vessels that are exposed to alveolar pressure, the resistance increase, as you can expect, as the alveolar pressure increase. Extraalveolar vessels that are in the interstitium have the opposite behavior. The resistance decrease as the alveolar pressure and the lung volume increase. Therefore, for patients who you want to decrease PVR, you need to aim at ventilation around FRC, or functional residual capacity. The other important concept that everybody, I guess, is familiar with is the concept of transmural pressure. So transmural pressure is the distending pressure of a chamber. That is, in an equation, the intracavitary pressure minus the extracavitary pressure. So when we talk about the heart and the lung, there are two transmural pressures to consider, at least. The lung transmural pressure, and this is a concept of respiratory mechanics, is called transpulmonary pressure, and is the difference between the alveolar pressure and the pleural pressure. The heart, that what we are more familiar with, is the difference between intracardiac pressure and pericardial pressure. Remember, as I told you at the very beginning, that the pericardial pressure in the end is a reflection of the pleural pressure. So in spontaneous breathing, when we take a breath, the pleural pressure comes down, so therefore the pericardial pressure would reflect a similar drop in the pressure. So when we talk about transmural pressure, I will remind you that afterload, in fact, is a transmural pressure. It's usually described as the pressure or load against which the heart contracts to eject blood. But afterload is not only aortic systolic pressure, because it's typically for us to think afterload the same as aortic systolic pressure. In the intact ventricle, represent the force exerted by the muscle during the contraction. And as you remember, force is pressure times area. So afterload accounts for the distribution of pressure over the surface to what the force is applied. In our case, when the force is applied to a thick spherical chamber as the LV, it is more accurately to describe by Laplace wall stress relationship. And here you can see that pressure is the transmural pressure times the radius divided by the wall thickness. So if you see this in an example, we have here three different, I would say, the same end diastolic pressure in three different ventricles. So in the first ventricle, ventricle A, yes, this is in diastole, not in systole, but it's a concept that applies for both, is 15, and it is surrounded by a pericardial pressure of 10. Imagine this would be a patient easily on mechanical ventilation. The transmural pressure is 5. In the second case, now what is happening is that the surrounding pressure is minus 5, so the transmural pressure is 20. Because transmural pressure speaks about the distending pressure of a chamber, the higher the transmural pressure, the bigger the chamber, and you can see the difference in size. In case number C, now we have a patient who has a very thick wall. And even though the transmural pressure is the same, if you remember the Laplace wall, the thickness of the wall reduces the wall stress on the chamber, and the chamber is smaller. Now, if you apply this concept to what I'm going to speak later, that is the interaction between the heart and the lung, now you think that the aorta is surrounded by the intrathoracic space. So if we go to the first image in a patient who is quiet breathing, you think that the pleural pressure would be between 0 and -5. So if you think about the transmural pressure at the aorta, in this case, if it's 0, it's 100, that is the intravascular pressure, the one that we can measure, -0, the transmural pressure is 100. Now the same patient is admitted with increased work of breathing in the setting of a cardiogenic shock. The patient still has, you put an arterial line, a blood pressure of 100, but now this is surrounded by a negative intrathoracic pressure, and this number, -25, is common in a patient with increased work of breathing. Therefore, now the transmural pressure that this LV is facing is 100 minus -25 is 125. So this LV is facing a higher afterload imposed by the negative pressure, by the swings of negative pleural pressure because of increased work of breathing. So we decide to intubate the patient. So we sedate, muscle relax, and now, instead of negative pressure, we have positive pressure ventilation. So now imagine the patient is breathing, and in the pleural space with every insufflation, we have a positive pressure of 20. In this setting, the transmural pressure now becomes 100 minus 20, 80. So by the fact that we intubate and take over the ventilation, we decrease the afterload of the LV. And this is one of the reasons why mechanical ventilation and positive pressure ventilation has benefit effect in patients with systolic dysfunction, LV systolic dysfunction. And this is the last is just to show you how you can read the same with vasodilatory therapy. The aim of 80 transmural pressure. So now coming back to the heart, thinking we need to remember that the RV and the LV physiology is completely different. And this is in normal circumstances. I will start with LV because most likely everybody is familiar with the pressure volume curve of the LV. And if you remember the cycles, the diastolic filling, the isovolumic contraction, ejection, and isovolumic relaxation are well defined. And this shape is a square. But if we look at what's going on in the RV, normal RV, we see that because it's pumping against a much lower resistant vascular bed, the diastolic filling continues with almost the ventricular contraction and ejection without any isovolumic relaxation time. That's why it has this hangout period where the exhalation start and finish even after the LV. This is important because in the settings of increased RV pressure, and this is something that we see in our population of patients a lot, this configuration begins to change to a more square one. But it's more important than that, the RV speaks of the fact that the RV leads or copes very poorly with a sudden increase of afterload. And this is the reason why in the setting, for example, of severe pulmonary disease like ARDS, the patient who have a normal ventricular physiology and circulation can present with acute RV failure that is called cor pulmonale. So now speaking about the interaction between the ventricles, and please, if you have any question, you can stop me and I can go over the questions as this is a review, a lot of concepts. So ventricular interdependence speaks about the ventricular interactions that are independent of humoral, neural, or circulatory effects. These ventricular interactions occur because of anatomic associations between the ventricles, and these anatomic associations are, they share the interventricular septums, and they are enclosed within the pericardium. To see it more clearly, this is a diffusion, I don't know this line, tensor magnetic resonance image demonstrating the orientation of myocytes. And you can see how fibers cross from the parietal walls of the LV to the RV. So fibers, myocyte fibers are present or are crossing the interventricular septum and being part of both ventricles. The ventricular interdependence now can be differentiated into the two, I would say, a component or aspect, the diastolic ventricular interdependence and systolic ventricular interdependence. If you look at the picture on the right, in a normal configuration, the LV is round, this is a short axis view, and the RV and the septums both to the RV. Even in a normal heart, we can see diastolic ventricular interdependence in situations like, for example, asthma, that accentuate this ventricular interdependence because of increased intrathoracic pressure. And this is the reason for the pulsus paradoxis. But if the RV is distended and the septum goes to the LV, you need to think that this RV filling and the septum bowing to the LV reduce the LV volume and therefore increase the LV and diastolic pressures. So the shift of the interventricular septum to the left side has important consequences in the function of the left side. And I will show you an echo that you will be most likely very familiar with, and this is a long axis view in a patient with a severe pulmonary hypertension. And you can notice how the distended RV and the wall, the interventricular septum, is bowing into the left ventricle and therefore impending filling. I say that because one of the strategies in this kind of situation, when there is a distended hypertensive RV, we use vasopressors as a way trying to counteract this septal displacement and improve ventricular-ventricular interactions. And when I say vasopressors, could be norepinephrine or vasopressin. If we talk about systolic ventricular interdependence, we need to think that around 30, or even some studies show up to 50% of the normal RV mechanical work is generated by the LV contraction. In normal circumstances, when the configuration of both ventricles is normal. In case of RV hypertension, when this is even suprasystemic, as I explained to you, the flattening of the interventricular septum also reduce LV assistance to RV ejection. So not only it has effect during diastole, but also during systole. Now, if you come back through to the positive pressure ventilation, and we think how we can modulate the PVR with positive pressure ventilation, you need to remember that the modulation of PVR can be done by two mechanisms. The first one is the one that I explained, that by changing transpulmonary pressure or by distending more or less the lung, we can cause the PVR to increase. So it's very important when we are aiming for the lowest PVR possible, to ventilate the patient around FRC. But the other way we can modulate the PVR is by altering the pulmonary vasomotor tone. And this is by, you remember that hypoxia and hypercapnia, because of the acidosis, cause pulmonary vasoconstriction. So the way we ventilate is important. In the patient we want the lowest possible PVR, we need to aim for a good oxygenation and a normal gas exchange. Typically is the case of patients with pulmonary hypertension. This mechanism of a hypoxic hypercapnic pulmonary vasoconstriction is mediated by nitric oxide changes and changes in intracellular calcium, because nitric oxide synthesis is inhibited by hypoxia and acidosis. And finally, the last physiological concept to review is the ventilation and perfusion zones. If you remember, and this is again, there are 3 zones in the lungs in the patient standing. This zone 1 is almost inexistent, but if you look at the picture, the distribution of gas and pulmonary blood flow has a vertical gradient. So in the zones, in the apical zones, the pressure, surrounding pressure, that is the pressure, alveolar pressure, is higher than the arterial component of the flow, therefore causing vascular collapse. In the zone 2, the alveolar pressure, that is the surrounding pressure, lies between the arterial and the venous pressure. And in zone 3, arterial and venous pressure is higher than the surrounding pressure. What is important of this is that we can create this zone. For example, patients who are ventilated with very high lung volumes, those who are hyperinflated, we may create zone 1. On the other side, remember that zone 2 can also be created by positive pressure ventilation and by insufflation. That is that every time we initiate a breath on mechanical ventilation, the surrounding pressure increase, which will have like a squeeze effect on the pulmonary vasculature and in fact increase the return to the left atrium, the pulmonary venous return. So if we take all of this together and we have the, I would say, extremes, a patient spontaneous breathing and a patient who is on positive pressure ventilation and muscle relax. It's very important when I say the patient is muscle relaxed, because when the patient is breathing, he will be more or less in the middle of what I'm talking about. But the extreme muscle relaxed patient and spontaneous breathing. So the inspiration, because of the decrease in pleural pressure, will facilitate systemic venous return. So it will increase RV preload in spontaneous breathing. But the opposite will happen when the patient is on mechanical ventilation and muscle relax. And this is very important because it's one of the biggest impact of positive pressure ventilation, the effect on the, I would say, preload of the right heart. The inspiration in both circumstances, because it augments lung volume from functional residual capacity to the end inspiratory volume, will increase the RV afterload. And I will show you a picture, beautiful picture of that. And this is regardless whether the patient is spontaneous breathing or on positive pressure ventilation. Inspiration in a patient that is spontaneous breathing will decrease LV preload for the mechanism that I already explained, the diastolic ventricular-ventricular interaction. The RV preload increase, this will slightly displace the interventricular septum, which can slightly increase the end diastolic pressures and decrease the preload to the LV. Remember that it's easier to see this if we accentuate this ventricular-ventricular interaction, for example, in patients with asthma, and this is the mechanism of pulsus paradoxus. But mechanical ventilation, each insufflation will increase LV preload by the mechanism I explained, converting some zones 3 to zones 2. Finally, and this is also explained at the very beginning of the talk, the LV, the inspiration will increase LV afterload, and remember the patient that say with increased work of breathing and negative pleural pressure of 25, how the effect that it has on the LV afterload. And the opposite will happen with mechanical ventilation. This is very important because the effect on LV afterload is even much more significant in the face of a dysfunctional LV. You can see exactly the same with this picture that I will skip because of time constraints. And the last point I want to make, and this is because it's a very beautiful study, old, it's like 1988, we look at the effect of PEEP on, if you remember, I told you pleural pressure is a surrogate, or I would say esophageal pressure. Okay, let's explain. Pleural pressure, because in order to measure pleural pressure, we should be using catheters. So what the way we have to minimally invasively assess pleural pressure is by using esophageal catheters and measuring the esophageal pressure, because the catheter sits in the lower third of the sternum. Pressure reflects closely what is happening in the pericardium. So it's not, the PES was used in this study not only to estimate pleural pressure, but also to estimate pericardial pressure. So this was a study with adult patients post coronary artery bypass surgery with different levels of PEEP. The patient had normal lungs. What you can see is as you increase the PEEP on those patients, the CVP and the left atrial pressure increase. It is not significant until we reach 10 or 15 levels of PEEP. You see that this also has a similar effect of increase in the esophageal pressure, that means the pericardial pressure, and as a consequence, the cardiac index drops with PEEPs that are 15 or more. This is again in patients with normal lungs. Remember that patients with injured lungs or lungs with, for example, if they have face ARDS, the transmission of airway pressure to the pleural space is less because most of the airway pressure will be dissipated to inflate the lung. So now trying to put this all together and finish the presentation, what are the effects of positive pressure ventilation on cardiovascular function in patients with congenital heart disease? So I want to remind you that ventilation in normal conditions, the respiratory muscles use around 5% of the oxygen. In the setting of increased work of breathing, that this is typically the case of patients, for example, who present with cardiogenic shock, the metabolic acidosis causes the respiratory drive to increase. This respiratory drive will respond trying to hyperventilate to compensate for the metabolic acidosis. So typically that this patient have a low pH with a low bicarb, but also a low CO2. In this setting, when the already delivery of oxygen is compromised, up to 30 to 50% of the oxygen may go to the respiratory muscles. So mechanical ventilation in the setting of a cardiogenic shock aims and helps for the redistribution of cardiac output. When we take over the work of breathing, we sedate and muscle relax the patient. Now this oxygen can be delivered to more other organs like the brain and the heart. I know that sometimes it's tricky because mechanical ventilation itself or the intubation could be a risk for a sudden deterioration of a patient, but the overall idea is in the setting of increased work of breathing and acidosis, mechanical ventilation help for the redistribution of cardiac output. Now, if we look at, now we will go through different congenital heart disease, the effect of positive pressure ventilation on cardiac output post ASD and VSD repair. So this patient has biventricular physiology. And you can see here healthy children and patients post-operatively who were ventilated initially in black is with positive pressure ventilation and in white with negative pressure ventilation. They were using negative pressure ventilation as a surrogate of spontaneous breathing. You can see how the cardiac index increased when the patient is switched to negative pressure ventilation in healthy children, but even more in patients after ASD or VSD repair. Talking how important is early extubation in these patients. Now, if you look at the effect on patients with LV systolic dysfunction, and this could be the same case for mitral regurgitation, you know that the mechanical ventilation, as I said, reduce LV afterload. And this effect predominate over any effect on venous return. As I explained before, reduce also the work of breathing and the consumption of oxygen by the respiratory muscles in the acute situation or in, like, for example, in the cardiogenic shock. So what it is important is when the patient are ventilated and we start weaning or the extubation is an exercise, and this patient needs to be monitored more in the setting of severely depressed LV dysfunction. For LV diastolic dysfunction, you know, there's not much we can do, but mechanical ventilation helps mitigate the consequence of increased left atrial pressure. In terms of the RV, and when I say RV failure, I'm talking about systolic and diastolic dysfunction. So RV dysfunction and mechanical ventilation are not a good combo, but there are things we can do to optimize the situation. So you know that mechanical ventilation reduces systemic venous return to the right atrium and increase RV afterload. And also there are important ventricular-ventricular interactions in the setting of a dilated hypertensive RV that are that have a consequence or negative consequence on the LV. So if you look at this picture, you have the aortic tracing, this is an hemodynamic study, and the right ventricle pressure tracing. You can see here when the initiation of insufflation and when the insufflation stops. So at the time the positive pressure starts, you can see how the RV pressure increased because of the increase in the afterload and decrease after. And this, as I told you before, because of the ventricular-ventricular interaction, the aortic pressure decrease. And I think that everybody has seen this in the arterial trace in the patient. So what happened with positive pressure ventilation on cardiac output post-tetralogy of allowed repair? This is also a small study, Reddington, that use a positive pressure ventilation and then switch the patient to negative pressure ventilation 15 minutes and 30 minutes after and measure the pulmonary blood flow. You think that this biventricular circulation, pulmonary blood flow will be the same as systemic output. You can see how after 15 minutes of negative pressure ventilation, the pulmonary blood flow increase and even increase further after 30 minutes of negative pressure ventilation. And again, the negative pressure ventilation is used as a surrogate of spontaneous breathing. Of notice, of these 8 patients, 4 of them has features of RV restrictive physiology. So we will take a look at them with more detail. So this is, again, the group, and you can see here the difference between, in black, restrictive and non-restrictive physiology. Black is from positive pressure ventilation to negative pressure ventilation. In fact, the group that respond the most in the first 15 minutes were the non-restrictive patients. But 30 minutes after, as you can see here, the differences was much more increase in pulmonary blood flow in the patient with restrictive physiology. And even if you compare from positive pressure ventilation to 30 minutes of negative pressure ventilation, patient with restrictive physiology can increase the pulmonary blood flow more than 60%. So how we deal with this patient? If we need to ventilate them, PEEP for FRC, for functional residual capacity. Don't be afraid if the patient has collapsed to increase the PEEP if you need. And I said that apart from suctioning and doing what's necessary, trying to bring the lung back to FRC. Avoid hyperinflation as much as possible and try to ventilate with the lowest mean airway pressure. If it's possible and there is no concerns of like very, I would say, difficult to manage low cardiac output state, allows spontaneous breathing because the little negative pressure that the patient can generate is beneficial. And remember that ventilate to a normal gas exchange to avoid a hypoxic vasoconstriction. The most important thing and you can do is extubate this patient as soon as possible. And this will improve the overall cardiac output. So what happened in patients with single ventricle physiology, and then I'm going to go quickly to the different stage. In the pre-palliation, when the patient hasn't gone to the OR yet, we remember that this patient has unrestricted pulmonary blood flow, unless there is a variant. I'm kind of talking about hypoplastic left heart syndrome, just to avoid all the anatomic variants of patients with single ventricle. But in the face of unrestricted QP, manipulation of PVR could be important. I mean, this patient ideally should be going to the OR because there is so much we can do. So these are the usual patients we are, if they have signs of pulmonary overcirculations, are on room air, so avoid any form of oxygen, trying to reduce the QPQS. And if the patient needs positive pressure ventilation in the form of a CPAP, could be non-invasive or mechanical ventilation, PEEP can help, and if you allow the CO2 to be mildly elevated. But remember, this patient, ideally, if they are in a situation that is getting worse, they need to go to the OR because we need to restrict the pulmonary blood flow. Post-palliation, that is not good with RV-to-PA conduit or a VT shunt, in our center is mainly patient with a conduit, the pulmonary blood flow is restricted by the size of the shunt or the conduit. So now in the post-operative period, what it is important is not like moving forward manipulation of PVR to manipulation of SVR. Your strategy should be aiming at maximize cardiac output. And I will show you a picture that is very clear in patient with, again, single ventricle. You see here different cardiac output and 500, 600, 700, and systemic oxygen availability. In the black line is the oxygen deficit. If we manipulate trying to maximize cardiac output with inotropic support, and if possible, reducing the SVR, overall, as you can see, even though the indifferent range of QPQS, overall, the systemic oxygen availability is higher. You can see here that ideally, the QPQS should be around 1 or a little less than 1 for a maximum cardiac output. If the patient goes to the next stage, that is the cardiopulmonary connection or BCPC, you remember that this is a specific population of patients with passive pulmonary blood flow. So again, this is similar to patients with RV dysfunction. The effect of changes in pleural pressure, venous return, and ventricular thinning predominates. So the way to ventilate these patients similar. We will ventilate with aiming for FRC, avoid hyperinflation, trying to reduce the mean airway pressure as much as we can. And again, spontaneous breathing, even I would say if the patient is possible, I switch always them to pressure support CPAP, trying to allow them to participate more on the ventilation and generate more negative pressure. There is a important point in patients with BCPC, and this is a study that shows that hypoventilation improves oxygenation after bidirectional superior cardiopulmonary connection. And you can see here in the 3 point, the baseline metabolic alkalosis and hypoventilation, and how hypoventilation increase oxygen saturation in the patient. In this study, the CO2 rise up to 58. So yes, in patients with BCPC that are ventilated, you can allow the CO2 to rise because this will vasodilate the brain circulation and increase the flow in the upper body, and therefore the flow in the pulmonary arteries. Again, the best thing we can do for this patient is extubate as soon as possible. And this is the last point because it's important to remember hypovolemia can be present in all cardiac patients as well as in pediatric ICU patients. Remember that hypovolemia, in patients with hypovolemia, the effect of positive pressure ventilation on systemic venous return is profound, and this can decrease the cardiac output. So how important is in the setting of hypovolemia is to, at the time we initiate mechanical ventilation, trying to have them well fluid resuscitated. And that's all. I have gone through the cardiopulmonary interactions and the way to maximize oxygen delivery in different congenital heart diseases, and I am happy to take any question if you have.
Thanks for your informative lecture. It was amazing. There are only 2 questions in chat section. The first one is, what is the effect of using vasopressin on the intraventricular interaction? Could you please tell your opinion about this?
Yes, and I will show you. So when I say vasopressin, you can also have the same effect with norepinephrine. So with a vasopressor, I'm going to, sometimes it's easier to go, okay, here. So I explain, in fact, in this picture, that part. In patient who has a dilated hypertensive RV, the septum goes to the LV. So how you can do medically to counteract this situation? So because there are some studies that has been done with surgical maneuvers, but in the setting of the cardiac ICU, increasing the afterload of the LV, more if the function allows, imagine the LV function is good, we can increase the afterload by vasopressin or norepinephrine. This won't change so much, but we'll try to compensate the effect of this bowing of the septum, trying to redisplace in a more of a neutral position, because a neutral position of the septum favors ventricular-ventricular interaction. So it's common practice in patients with a hypertensive and dilated RV that in the setting of mechanical ventilation and need of therapy, inotropic or vasopressor therapy, our preference would be try to keep the blood pressure in the higher side of normal if the LV function allows, because of the effect on the septum and also the effect, if you remember, on coronary perfusion as well.
Thank you. And the second one is, does PPV affect on coronary circulation in critically ill child?
Coronary
Coronary circulation.
and PPV. Okay, so if we think about coronary circulation, so normal circumstances, the coronary circulation in the LV happens in diastole, and it's the difference between diastolic blood pressure and end diastolic LV pressure. So it does, I would say, mechanical ventilation in the setting of a, you need to, I would say, think what is the physiology that you are dealing with. In the setting of an LV dysfunction, for example, mechanical ventilation can even help because reduce LV afterload, okay? And this reduction in LV afterload can improve the cardiac output. If you improve the cardiac output, will improve the coronary perfusion, okay? In the setting of RV dysfunction is when I said mechanical ventilation and RV dysfunction are not good friends. So you need to try to deliver the mechanical ventilation, minimizing the negative effect of that. But because one of the ways in order to improve coronary perfusion is the improvement in pressures, and therefore sometimes this patient, because they need to be sedated in order to tolerate mechanical ventilation and the blood pressure drops, the effect to counteract this is not by mechanical ventilation, but by the use of vasopressors.
Thank you. And our dear professor, Dr. Aghay, has some question. Dear Dr. Aghay.
I just wrote it down in the chat section, but I can say it right now. What is your preference to manipulate the systemic vascular resistance in a patient and the effect of that on the interventricular interactions? You know, which drug, which medication do you use for that?
Okay, so depends again. So first of all, it depends what you have available. I also would say depends on how long we need to decrease the SVR for and the age of the patient. So if I come back to the single ventricle that is the population that I said, let's say manipulation of SVR in the postoperative period is important. Imagine you have a patient who is after repair with an Norwood and RV2PA conduit, who on top of this has a saturation in the high 80s, and you want to maximize cardiac output, apart from if the patient has some form of dysfunction, to put epinephrine to include the inotropic support. If the blood pressure allows, you would like the blood pressure to be in the, I would say, lower side of normal range, because the lower the afterload, the bigger the stroke volume. So in a setting of a small baby with a Norwood that may take days of this patient to have a good balance and move forward, in that setting, I prefer not to use nipride. Nipride is a nitroprusside, how do you call it? Nipride. Because of the toxicity is more of a problem in neonates. Second, these patients are at risk of acute kidney injury, and the combination of neonate and acute kidney injury even increase the risk of nipride toxicity in neonates. So we have in our unit phentolamine, and I prefer, and this is a preference that is shared by me and some of my colleagues, to use phentolamine in this situation, because the risk profile is more beneficial. Yes, it's not as the nipride, you start, it has an effect, you stop. Phentolamine takes a little more of time because the half-life is longer, but you are going to treat this is for days. So we use or we prefer phentolamine. And I say this on top of milrinone. I forgot to mention this. All these patients come from the OR with milrinone. So for us, milrinone is part of the standard inotropic combo. If they have some form of RV dysfunction, we add epinephrine. And in the case of reducing SVR, we prefer phentolamine. Now, if you'd ask me, the patient who presented in cardiogenic shock, and I have a patient with a new diagnosis of DCM that I remember she presented, but in this case, usually if the shock is in the late phase, all of them will be hypotensive. But if it's not so late, some of them, as a response to the reduced cardiac output, will increase the SVR. And the combination of increased SVR in a dysfunctional LV and dysfunctional LV, and in this case also had mitral regurgitation, was not good. So in that setting, the patient was bigger. It was like for some hours, you say 1 or 2 days, that you take control of the situation, you improve the cardiac output, and you reverse the shock state. In that situation, you may use whatever you have, a part of milrinone, because milrinone was already added, but nitrite, or if you want phentolamine, would be good options. If you are very afraid that the vasodilator can cause hypotension, and you may say, okay, let's start with nitrite because of the short half-life. If it doesn't tolerate, I stop, because phentolamine is a little longer. And this is another consideration. And very important is if you are going to start nitrite, to take a look at the renal function.
Thank you very much, dear Dr. Luciana. It was a great presentation by you. It was a very complicated and difficult presentation, but you did it great. You know, we actually enjoyed that, and it was fascinating. If we have time, we wanted to continue the discussion with you for hours, but sadly we do not have enough time. Maybe another time we can join you, and you can help us with your knowledge and your science.
I thank you very much.
Thank you very much.
Yeah, took the opportunity that I saw that Alex was not presenting to explain a little more of mechanical ventilation, because I knew that they can overlap, the talks could overlap a little. I will tell him, because he will be sad when he knows that his presentation didn't work, but you know, he's on service today, so it's working.
So if we do not have Alex with us for tonight, because we do not have enough time to have his presentation here, we can just put the presentation live on our website and also YouTube. And if there is any questions from Dr. Luciana, we can now ask her, and if not, we can end our session right now.
Okay.
So, dear audiences, is there any questions that we should ask dear Dr. Luciana? If not, we can just say goodbye and thank you very much for participation in this session. Thank you. Thank you very much. Thank you, Dr. Desai. It was a great honor meeting you, and thank you for your time and for your patience.
Thank you. Bye-bye.
Thank you.
Bye-bye. Bye-bye. Thank you very much. Have a nice day. Bye-bye.